Jyoti,
Yes.
take over.
A very good morning and warm welcome to all the eminent faculties, respected seniors, and my dear friends. Today's scientific meeting is a part of KSOS CME series. It is on ocular trauma, minimizing damage and maximizing vision. It is conducted in collaboration with the Ocular Trauma Society of India and is being conducted by the Thrissur Academic Club of Ophthalmology, that is our TACO. Ocular trauma accounts for the most common cause of emergency visit to the hospital for the eye problem. Many of these cases can have a medico-legal aspect also. Hence, it is important to take a detailed history, do a meticulous examination. Doing the relevant investigations and maintaining proper documentation is also needed in addition to the actual treatment. Today, we have well-known senior speakers from Ocular Trauma Society of India to enlighten us. With such eminent and experienced speakers, no doubt this will be a very useful CME. We will start today's CME with a prayer by Dr. Geetu from Government Medical College, Thrissur.
നന്മയാകുന്ന കാന്തി കാണുവാൻ കണ്ണിനാകേണമേ നല്ല വാക്കിൻ്റെ ശീലു ചൊല്ലുവാൻ നാവിനാകേണമേ സ്നേഹമാകുന്ന ഗീതമോ എൻ്റെ കാതിലിണയാകണേ സത്യമെന്നുള്ള ശീലമോടെ ഞാൻ ശാന്തിയറിയണമേ ഭൂമിയമ്മ എന്നറിയുവാനുള്ള ബോധമുണ്ടാകണേ ജീവജാലങ്ങളാകിയും ജന്മബന്ധുവായിടണേ ജാതിഭേദങ്ങളെന്ന ശാപമോ ദൂരെ മറയണമേ ലോകമൊന്നെന്ന പാഠമെന്നുമെൻ മനസ്സിലെഴുതണമേ ലോകമൊന്നെന്ന പാഠമെന്നുമെൻ മനസ്സിലെഴുതണമേ.
Thank you, Dr. Geetu. Now I call upon Dr. Sudhavi, our active and efficient president of TACO, to deliver the welcome address. Dr. Sudhavi. Mic on. Sudha.
Dr. Sudha, you're there?
I think it is mute.
Dr. Sudha? I think she has a problem with connection probably. So I'll because we can't delay the inauguration session because the scientific session will get delayed. I'll do the welcome. First of all, I welcome all the participants, delegates, faculty members to the fifth in the series of Ksos Scientific Committee CMA series. So,
from back, sir.
Dr. Sudha? Okay, please, yeah. please.
Okay. So I also welcome the twin pillars of KSOS today. Dr. Gopal Pillai, General Secretary KSOS, and Dr. Srini Adikalan, Chairman Scientific Committee to this program. Dr. Srini has been the driving force for these CME modules and guided us at all steps. Dr. Prashop Mohan, Member Scientific Committee, has been an active support. Welcome to you all.
Dr. Sudha has an internet connection issue. Dr. Arup sir? Arup sir?
Muted. Can you hear me now?
Sir? Yeah. We welcome you for the inaugural address and inauguration of the CME.
Okay. So, good morning, everybody, and a hearty and warm welcome to all the viewers for this webinar. I would like to welcome all the viewers and all the delegate members, all the faculty members to this webinar as President KSOS. On behalf of KSOS, we also have our dynamic secretary, Dr. Gopal, and scientific committee chairman, Dr. Srini, in this program. At the outset, I'd like to thank TACO for organizing a CME program on this magnitude. You know, it is basically the who's who of the Trauma Society and Indian ophthalmology among the faculty members. Lovely topics laid out in front of us. And I am sure these talks and these deliberations are going to be of immense benefit to the people, for the viewers of this CME program. I would also like to thank TACO for all the work that they have been doing over the years in the academic field as well as in the other fields. They have been on the forefront actually among most of the district clubs in KSOS. So please keep up the good work. And I inaugurate this meeting and wish you all the best and a very good learning experience. Thank you so much.
Thank you, Arup sir. We are happy to say that on behalf of TACO, a moment was given to Grover sir. We are happy to say that on behalf of TACO, a moment was given to the President, Ocular Trauma Society of India, Padma Shri awardee, Dr. A.K. Grover. It was handed over to sir. It was handed over to sir on behalf of TACO by the manager Rajendra Pharma. Now I invite Dr. A.K. Grover sir to felicitate the function.
Good morning, everyone, and thank you for this singular honor and for having involved the Ocular Trauma Society of India in this such an important activity. I think the choice of subject is very apt: ocular trauma, minimizing damage, maximizing vision. So I think the choice of the subject of ocular trauma for this CME series number 5 is most welcome, and I thank the KSOS as well as TACO for having thought of this subject and having organized this meeting and having made the Ocular Trauma Society of India a part of this activity. Ocular trauma, as we know, is a very important cause of loss of vision in the entire world. And a lot of effort has recently been made by some of the organizations to increase awareness, to improve the documentation, and to move towards better outcomes by utilizing the services of all subspecialties, developing specialized ocular trauma services by integrating the services of different subspecialties. So that is all most welcome. So I would like to thank Dr. Arup Chakrabarti, Dr. Gopal, all my dear friends, Dr. Srini, Dr. Sujata V, Dr. Jyoti, Dr. Sujata N, also my own societies, Dr. Mehul Shah and Dr. Prasanth Bhavankule, for this wonderful effort. It will take a lot of our effort to make sure that ocular trauma gets its due place in the subspecialties of ophthalmology. At present, there are no specialized fellowships. At present, there are no specialized subspecialty exams in this subspecialty. And as a result, the integration of subspecialties for taking care of ocular trauma at many centers is still quite poor. Also, documentation has been a problem, and we are very happy that Rupesh has started this IGATES registry, which he's here to talk about, which is going to make us aware as to how we can improve our documentation and make sure that we know much more about ocular trauma so that we can manage it well. Ocular Trauma Society of India is working towards increasing awareness in general public and amongst ophthalmologists to make sure that we are able to take care of these patients well, also do a lot to prevent what can be a very, very important cause of loss of vision. So thank you again, everyone, TACO, KSOS, and OTSI for this superb effort and a wonderful scientific program that has been put together. Thank you all for this effort.
Thank you, Grover sir. Next, I invite Dr. Mehul Shah, Honorable Secretary of Ocular Trauma Society of India, to felicitate the function. Mehul sir.
Thank you very much. We are honored to have a collaboration with KSOS and TACO for this wonderful meeting, and it is a great initiative to make the awareness and efforts on the district level. And we knew about your viewership program that will help us to make more people aware about the ocular trauma. It was a past belief that once the injury, people hardly get vision, but with various efforts of Asia Pacific Society, ISOT, and Ocular Trauma Society, there are a lot of technological innovations. There are many research and publications and presentation which will provide the idea to the general ophthalmologist how the vision and eye can be salvaged. And we have some stalwart speakers who will highlight these aspects. So we hope that everybody will be benefited by the knowledge and feast of this academic session. Thank you.
Thank you, Mehul sir. Now I call upon our own TACO member, Dr. Gopal S. Pillai, Honorable Secretary of KSOS, to felicitate the function.
Gopal might be traveling. Has he joined? He might not be able to join. If he's not joined, let's skip us.
So next I invite Srini Edklon, Dr. Chairman Scientific Committee KSOS, to felicitate the function.
Thank you, Dr. Jyoti. Dr. Gopal, our General Secretary, is on the way to Calicut for venue inspection for Registry 2020. So there's some disturbance of it. Okay. First of all, let me thank Ocular Trauma Society of India, Dr. Grover, Dr. Mehul Shah, and our esteemed faculty, Dr. Rupesh Agarwal, Dr. Prasanth Bhavankule, Dr. Natarajan sir, for being part of, for joining hands with KSOS and TACO to conduct such a wonderful program. Dr. Natarajan, sir, are you still there?
I'm there.
Sir, I think I'll conclude my words, and I would request a few lines from you.
Oh, no, I actually, my passion for the ocular trauma is from my postgraduate days. So I love working on ocular trauma. Then I did maximum trauma in Shankarnetralia. Thanks to Dr. Ashok Grover for asking me to be here as a past president of the Ocular Trauma Society of India. So I'm associated from the inception with Dr. Oprai and Dr. Shukla. So it's a great thing that Kerala State Ophthalmic Society is doing. And I think the topic, as Dr. Grover said, is amazing, like minimizing the trauma and maximizing the vision. And I think that's the most thing we have to do. It's, as Dr. Mehul said, it's not like a gone case now. Even a vitreoretinal surgery following ocular trauma, you can get 6/6 following whatever, you can put the intraocular lens, everything. I think not all cases are good. Only one thing I want to say is, which I'll be highlighting during my talk, will be whatever trauma happens, please, everybody should repair it as though that I will see. This is what I just want to convey. Don't say that it's a very bad trauma and can't do it. Anyway, we have to medically take care, under promise and promise less and deliver more. Thank you. Thank you, Sinha.
Thank you, sir. Dr. Jyoti, carry on.
Jyoti, you're mute. Jyoti, mute.
Now I invite past president of KSOS and senior patron member of TACO, Dr. Alex Joseph, sir, to felicitate the function. Alex, sir, welcome, sir.
So please unmute yourself.
Yes, sir, was there.
Am I audible?
Yes, sir. Yes, sir.
Okay, a very good morning to all. Dr. A.K. Govar from Ocular Trauma Society of India, Dr. Anup, Dr. Gopal Pillai, and Dr. Srini from KSOS, Dr. Sudha, Dr. Sujada, and Dr. Jyoti from TACO, the resource persons and fellow ophthalmologists. At the onset, congratulations to TACO and KSOS for organizing a CME on ocular trauma and the Ocular Trauma Society of India for its active participation. I thank the organizers for giving me an opportunity to give this facilitation. As a result of the high-end vehicles and high-end roads, there is a rapid increase in road traffic accidents. The industrial accidents are also in the increase. As a result, nowadays we meet a lot of ocular injuries. If you look half a century back, of course, when I started my ophthalmic practice, the aim of the managing ocular injuries was only for anatomical approximation, least important for the visual rehabilitation. The scenario has changed now. After the introduction of modern microscope, instruments and sutures, etc., the priority is now to regain maximum vision after the repair. So such CMEs are highly essential for our fellow ophthalmologists. The CME will be very fruitful and useful for the modern ophthalmic surgeons to reach this goal. I wish all success for the CME. Thank you.
Thank you, Alex, sir. Thank you for your wise words. Now I call upon our sincere and dedicated secretary, Dr. Sujada, to deliver the vote of thanks.
Thank you, Jyoti. Good morning, ladies and gentlemen. It's my proud privilege today to offer vote of thanks to this august audience. I thank Dr. Arup Chakravarti, our dynamic KSOS president, for inaugurating the session and for the presidential address. Thank you, sir, for your kind words. Now, on the behalf of every member of the Thrissur Academic Club of Ophthalmology and on my personal behalf, I would like to thank Dr. A.K. Grover, President of the Ocular Trauma Society of India. Sir was instrumental in arranging the eminent national and international faculty for our CME. And I also thank him for his felicitations. Thank you so much, sir. I thank Dr. Mehul Shah, Secretary OTSI, for his all timely help and for his felicitations. Thank you, sir. I thank Dr. Gopal S. Pillai, Secretary KSOS, for all his help and though he was absent today, I thank him for all his help. Thanks are due to Dr. Srini Edaklon, Chairman of the Scientific Committee KSOS, for his immense help in organizing this CME and for his felicitations. Thank you. I would like to thank our senior patron member, Dr. Alex Joseph, sir, for his kind words today. Now I would like to thank Professor Dr. S. Natarajan sir and all the eminent national, international and Ksos faculty for joining us today. Thank you, sir. I also thank the chairpersons of the different sessions of today for their valuable contribution. Then, from the bottom of my heart, I thank all the senior faculty KSOS members who have joined us today. Then, I would like to specially thank 3 members of our team, Dr. Roland Totley for arranging the memento, Dr. Tanishri for her exquisite design of the CME flyer, and Dr. Geetu for her prayer song. I thank Dr. Mr. Ankit for the technical support and KSOS for providing the Zoom platform. Once again, I thank each and every one of you separately. Thank you all. Have a great day.
Thank you, Sujata. With this, we come to the end of the inaugural function. Now we move on to the scientific part. We can have discussions at the end of each session, and audience can message their doubts in the chat box. First session is on general trauma management. Session will be chaired by Dr. Sudha V, Professor, Government Medical College, Thrissur. Over to Dr. Sudha.
Thank you. Dr. Srini, can we start the session? We are a little early, actually.
We can start,
Okay.
Dr. Sudha, like the introduction and all will start. No issues.
Thank you, Dr. Srini and Dr. Jyoti, for giving me a chance to chair our first session. I'm sorry I was not able to complete my welcome, but certainly a big welcome to all of you. In this first session, we are discussing the basic trauma care principle in this 1 hour. And we have an excellent faculty joining me with me today. I would like to just introduce you. So our guest faculty will be Associate Professor Rupesh Agarwal. He is, of course, the teaching head for a lot of medical colleges in Singapore. But at the same time, he's also a research deputy head, research and head of Tan Tock Seng Hospital, Singapore. His main interest has been in tuberculosis and uvea, and of course, trauma. And he's been the lead investigator in COTS, IGATES, etc. He did his post-graduation and fellowship in uveitis and ocular trauma from Shankar Nethralaya, Chennai. And his research training fellowship he was given and awarded by the Ministry of Health, Singapore. And he did this at the University College London on retinal imaging. He's published extensively on ocular inflammation and trauma and has presented numerous papers and lectures nationally and internationally. And he's been conferred with the Healthcare Humanity Award by the President of the Republic of Singapore. So welcome to you, sir, and we'll be happy to hear your talk as a first. We also have eminent KSOS faculty, Dr. C.V. Andrews, who's the Medical Superintendent of Jubilee Mission Medical College and Research Center, Thrissur, and Dr. Thomas George, Senior Consultant at Chaitanya Eye Hospital, Trivandrum. So welcome to you all, sir. And I would like to first invite Dr. Rupesh, as he has some other talk to attend to. So please, sir, can you start?
Thank you, Dr. Sudha, and all the respected members for giving me the opportunity to share some of my experience. Let me see. I will try and use a couple of different slides, and it's just that computer is a bit slow. It will take a couple of minutes, maybe less than a minute to load it. The top. Yeah, sorry for that. So basically, what I am intending to present in next 10 minutes of my talk is about the value of data collection and why we need to do that. So we do know that data is the key, and data is the new currency, as we all understand very clearly. Now, when we talk about data is the key, and this is a very famous from Sir Arthur Conan Doyle, one of I'm sure all of you know this author, who has written very clearly, I never guess. It's a capital mistake to theorize before one has data. Insensibly, one begins to twist facts and theories instead of theories to suit facts. So this is something very deep meaning, and if you put it really properly, we do say from my experience, I have done this, I will do this, I have seen this. I think that's not enough. Probably we need to have the data. And unfortunately, in the trauma, there are many areas which are lacking, including the area of training. But the number which is very striking is data coming from 2012 or maybe 2014 and before that. We don't have really the data coming from the India, and maybe Dr. Lali Dandona and someone else, we have done some of the large epidemiology study, but nothing has come up in recently. Now, when we have to kind of consider where do we want to move trauma towards thing there, and these are some of the slides I'm not kind of interested right now in showing, but the fact about current status of trauma is that there are only limited eye injuries which are classified, does not take into consideration the important structures of the eye, does give a lot of value to visual acuity and REPD, and zone 1 is not been kind of classified properly, and zone 3 is not classified. And this is where I think a friendship or kind of a collaborative aspect come between all of us, and which involves not only the collaboration between the scientific societies, but also.
Okay, can I interrupt you? I think the slides are not moving.
Oh my goodness! Sorry for that. Sorry. Okay,
And the
I did
present
not realize.
not full screen also.
Sorry, I did not realize. Sorry for that. Okay. Okay, let me see. Sorry for that. I did not realize that. Let me try something. But anyway, just to continue with my talk on the data collection.
Dr. Rupesh, we started early, so no problem. You fix your issue.
Yeah. Sorry. Okay, I will move to the platform which you created. Can you see the platform now?
Yeah. Yes.
Yeah. Good. So I'll just keep it in this mode, because when I'm trying to make it like a big screen, then not able to do that. So this is better. So this is the trauma data collection platform, which we call it as IGATES, which stands for International Global and National Trauma Epidemiology Study. What it does, it allows all the major societies to come together. As you can see here, we have Ocular Trauma Society of India, we have Chinese Ocular Trauma Society, we have Asia Pacific Ophthalmic Trauma Society, we have American Society of Ophthalmic Trauma, International. So this is the first time all the societies got together to think. We are still kind of getting AIS on board, and it will be rolled out in a major way, and Dr. Natarajan is facilitating that. We have got also EPTOC. So all the societies got together to conduct a large-scale ocular trauma study, and under which we have prepared this platform, which you can access it right now. How do you access it? I will just show you. So you go into the login, and each site will get their own separate login. So this is my login, and you can see the number of data points which the patients which you have collected so far, and the sites which we have. So you can see the different sites. So these are the sites from Singapore. We have sites from India. We have Jakarta, Indonesia. We have sites from Malaysia. We have sites from Sydney, Australia. We have sites from Tehran. We have sites from Chitrakoot, Colombia, and Central India, Calcutta as well. And then we have Singapore, of course. As I said, Nepal is also part. Mexico is a part of it. Guatemala is a part of it. So where you would have thought that we can probably have all the sites at one common platform, linking up together towards a common vision to prevent the injury. We have even Pakistan here as well. You can see here, very dear friend, Dr. Amar is already entering the data here, and we have Argentina here, US here as well. You can imagine the platform and the richness of this platform, which will allow all the centers to use a common language to talk between them. A registry platform where they can collect data for retrospective as well as prospective. Now, how do they collect it? So let me show you how do you collect it. So when you go, and let's say this is your hospital portfolio, like any electronic medical record, you just go in and say, I want to create a new record. Once you say create a new record, so I have access to all this thing as an admin, but let's say I'm just giving you a demo. So your site name is demo. You can create, it is a retrospective patient or a prospective. You can create both for retrospective as prospective. So this is the first time any platform allows data collection for both prospective as well as retrospective. And you can retrieve the data even after 10 years. So that's the beauty about this platform. So let's say you have a prospective patient came to your clinic. You will get a very unique ID for this patient. You can enter patient demographic detail, let's say whatever you want to say. And we have taken care also of the data protection points, including the patient identified. So none of these are patient identified, including the date of presentation we are not recording. And you can also record the number of days post-injury, hours if you have exact information. And you can also classify days less than 12 hours, more than 12 or 24 hours. You can also kind of classify the race based on where the patient is coming from. The patient is coming from Cambodia, you can say that. And then past medical history, was there any diabetes, hypertension? We are just recording some simple history, not going into too complicated detail, because more you enter the information, the people will not be able to kind of, will lose interest. And I'm really proud to say that the most data entry has come from no other state other than Kerala by our dear friend Dr. Giridhar. So we'll show you later on the results of this. So you can also enter the ocular history and any ocular surgery was done. So once you have done this, you save it and you move to the next page. So automatically the page moves you. Now, I am sure all of you will agree based on experience. A lot of times when we collect the data in our electronic records form, we don't collect it in a very standard way. We kind of type something, we miss out something. So here, as an education tool, as a research tool, you are guiding a doctor or a physician or a resident or a medical officer or a medical student to enter certain points which all of them can understand. So which eye was involved, where was which eye is worse. So let's say worse is the right eye, or maybe you can say the patient got right eye injury, then it will not come up. Where the patient got injury, he got injury at home, there was an accidental injury and there was no eye protection present. But once you say eye protection, it will ask you further question. What kind of thing was there? Patient was wearing goggles. Then what object resulted into injury? Do you say it was a sharp metallic object, or maybe you can say iron here or something, which resulted into injury, and there was associated head injury. So you can say there was an associated life-threatening injury, if you want to say that. And this is the first time someone is ever recording the information about the non-ophthalmic injury along with the ophthalmic injury. Once you complete this, it will bring you to the injury page where you have to enter the information about the visual acuity, which is all drop-down, different kind of annotations are there. Both eyes will record the vision, but only thing for the right eye, the injured eye, you will record all the information in detail. Is there a RAPD? Is there a corneal injury? If there is a corneal injury, is the visual axis involved? Is the limbus involved? Is there iris injury? Then what is it? Is it iridodylisis or it is just iris prolapse? So maybe iris prolapse. Anterior chamber involved? Yes. There is a fibrin lens matter. There is a hypopion. There is a hypema. You can say whatever findings you want to say. IOP was not assessed. So we have kind of kept a finding. If it is not assessed, you can do that also. Lens injury could not be assessed because there was a obscuration or something like that. Scleral injury was not there. We could not see the vitreous injury because not able to assess. So there is a difference, not able to assess and not assess. Here, I was not able to assess. Retinal injury, again, not able to assess. And choroidal injury, not able to assess. Endophthalmitis, maybe you can say maybe yes. Foreign body, you say maybe yes. And then you ask foreign body location. You say foreign body is in the vitreous. Then which type of foreign body? You say organic foreign body. You can also describe about the foreign body. No optic nerve injury, no intracranial injury, no lid injury, no orbital injury, no laser. After that, it will ask you which type of injury you are dealing with. And you say patient has a globe rupture, or you can say patient has a penetrating injury with a sharp object, and this injury belongs to zone 1. But zone 1 with posterior involvement of endophthalmitis. And patient underwent surgery, underwent at 3 days, and surgery detail was primary globe repair with vitrectomy, with maybe IFB removal, if you want to say that. You just say that and save. Yeah, that will take you from, if some key information is missing, it will ask you again. Now, I wanted to tell you just a single minute, which I'll take your time, is once you enter this information, you don't have to go to your books looking at the ocular trauma score. This will be automatically generated here. So here you see the ocular trauma score based on the information you entered, where globe rupture score was written, endophthalmitis was -17, and all this thing, it will take you to an ocular trauma score. So let's say if I have to change this to globe rupture, so automatically the score will change. So if I have to go back into this, I say, no, this was not penetrating injury. Let me just change it to globe rupture. So you will see the score instead of zone the 3 OTS, you will see the score has become 2 because globe rupture is given with -23. So this is all happening live. You can enter the information, you can enter the whole information, you get a prognostic chart there in front of you, and you can also upload images, you can upload video of surgeries, you can upload video of clinical examination, you can add up as many follow-up visits as you want. You say patient came at 2 weeks, submit. This is 1 visit. Patient came at 4 weeks, submit. You can add up as many number of visits as you want, and the data will be collected. So this is how rich source of information it can become for OTSI, become from Kerala State Society, become for AIOS, become for international trauma societies, where you have the information. Now you will wonder what will happen next. So now what we haven't put it is something, a next screen. So can you see my next screen, which is the data analysis? Now this data has come from all over. So when you click on that portal, automatically at the same time, like what we used to see COVID, how many cases of COVID are there in Kerala, how many cases of COVID are in Delhi and wherever in North India and all, you can divide it. So now this is based on the entire data, but I am only interested in looking at India data. So I say India, so this will give you an overall picture of data coming from India. Then if you want to just see data coming based on the sites, so these are the sites in India. You say Drishti Netralaya Gujarat has entered 421 records, NKP Salve from Nagpur has entered 51, Shankar Deva Netralaya from Guwahati has entered 48, and this is where I was saying Giridhara Institute has entered 879 records. You know, so that is how they are entering the information, and you can get lots of information about the race, the month of presentation, duration of presentation, and this whole information is available for you for research, for your training, for education, talking to the government agencies, for your publications. So each center can pull out their information, write up papers after papers, present it. We don't want to be the body who is controlling the data. We want to give you the platform where you can put up your data, you get the analysis. At the same time, you become a part of the international study, but at the same time, you control your data as well. So this is how I believe we can take it forward, the contribution or the trauma to the next level. And I really need support and guidance from all of you. Thank you very much for your patient listening. Thank you.
Thank you, Dr. Rupesh. That was an excellent talk. Can you take a few questions before you leave?
Yeah, I'm good. Yeah.
Just to be more clear about this, we already have a terminology of the BETS terminology. So what exactly is the change that you're planning to do with this study?
Good. So thanks. So number one is the terminology is quite old, 1992, and some of the terms are loosely defined. So through our consortium, we probably will relook into those terminology, see if it stands today or if we need to change some technology. So the paper is in review, where we have generated a consensus guidelines about relooking into the terminology and can we change it. And the change is for better. Change is to allow us to prognosticate an outcome. So when we talk about a blunt injury or anything, we should be looking at outcome so that and how the terminology can be used as a common language in the clinic. Because right now also people misuse the terminology between. So we are trying to create a platform where automatically a terminology will come to you rather than you changing the terminology.
May I just add something? I think what Rupesh has repeatedly emphasized again and again is that it is about ophthalmic trauma. So it also has made a very good effort at characterizing and giving the proper importance to adnexal trauma, orbital trauma as well. So you can enter that data as well, very well. So all those things that were not covered by BRETS have also been covered. And then it is possible to use this data to analyze it and to make your own research publications. I think that is one aspect that this IGATES has done, making it a more comprehensive ophthalmic rather than ocular trauma.
So that's great. And how secure will this data be? When somebody puts it in there, we should also talk about that security.
Good. So this is currently on the AWS cloud. So there are 3 different levels of security. So through different levels of AWS, whatever it offers, so it is a very password protected, encrypted data. So number one, what we have tried to do, even we are from baseline, we think it is not secure. So we try to make it like a de-identifier tool. So anyone can hack into this data. They will not get anything. They will only get, there is some scattered data there. The second thing what we have done is we have used some of the blockchain technologies to make sure that when someone hacks into it, they will get it as scattered pieces. Some demographics page will be separated. Then the whole injury page will be separated. The follow-up page will be separated. They are all kept in different boxes based on the blockchain technology. The third very important thing is that some people are not very keen to put it on the cloud. So this is currently on the cloud. We have developed a platform. Right now, I don't have that box, but is there a box? And that box can be implanted and can be put into your clinic on your computer. And within your own intranet system, you can try and enter the data, and the data will never be going on the cloud on the internet. So the Australia, one of the site in Melbourne is using that, and Indonesia, one of the site will be using the box, and that box is called as IGATES box. And we will share the details after we getting approval from EPOD's board. So we are just trying it at Indonesia. If that box is useful, then you can just put it there box in your clinic, and your entire clinic can run and use that software, and we will not get access to that data also. I will not get access to that data. Different levels of security.
Rupesh, wonderful talk. Now, for the benefit of Kerala state and Thrissur and all over India, have to become member of APOTS to enter IGATES?
Not compulsory, but we do encourage they should become a member of
I thought first is a forum like this. I know I'm not recommending member, but I think they can all be encouraged to enter APOTS, and then later when they find interesting, they can become. Many people may not be interested in the international one, but I think one or two maybe. But the rest, I think at least they can be encouraged to enter IGATES. And I think optometrist and all the postgraduates, I'm pushing them, but it's a problem. Daily you have to remind them.
Yeah, it's a good example is Dr. Giridhar's efforts. You can see that, and Dr. Mehul's efforts.
So that's one doubt there. Is there any legal impediment to do this, to sharing of data?
No. So we have to get some data sharing agreements and some of these places, but there is no legal kind of impediments about that. As far as you are not sharing any identified data, and it is quite all right. You have to clear ethics, of course, local center ethics to enter this data, but there are no legal challenges of this thing. Yeah.
I would like to add something that through this IGATES platform, I think many research publications have come out, and then you must have seen that the collaborative efforts of different society, and it has been very effective. Number two, it is very compulsory to our hospital that all the doctors are supposed to be the members and uploading the data in distributed fashion. So they will upload, and then we can upload the large number of data.
Thank you, sir, for that illuminating talk. And I'm happy to have you here. And I will move on to the next talk by Dr. Andrews.
Thank you.
Talk is about basic management and actually approach to a patient. And the initial examination actually has a good impact on prognosis. So to initially examine, we should also be very careful about certain precautions there. And so management always deals with an excellent examination. So over to you, sir, to talk about this.
Good morning, everybody. Sincere thanks to Ocular Trauma Society of India, especially Dr. Agarwal, my old friend for last 30 years, as well as Ksos and Taco for giving me an opportunity to talk on the topic of ocular trauma.
Andrew, I'm more friend than you, Grover.
Sorry.
Sorry.
Ocular Society or Trauma Society, Grover is, I only introduced Grover for this symposium. So he has taken over. I recommend Sudha for Grover's name. But I cannot forget Natarajan sir. I know him for last 35, 40 years. So welcome Natarajan sir also. So when you take an initial emergency care, so usually trauma patients will come to the casualty. So you should be very careful. So it may be polytrauma or RTA or something like that. So the first thing is life-threatening injuries should be avoided. So there can be multiple injuries, multi-organ system or something will be affected. So life is more important than the ophthalmic problem. So you should first see what is a life-threatening injuries. Then you take a past medical and surgical history, that is important. Then only come to the proper ocular history. Then you should have a detailed eye examination. And suppose there is a chemical injury, especially actually when first thing is to give a ocular surface lavage. That is more important before taking the history also. So as an ophthalmologist, you should first take a clearance for the medical, surgical, neuro clearance, because there can be multiple problems also. Then you have to see the vital signs like pulse, BP, and you should have some diagnosis test result, especially blood sugar. Then only you come to the eyeball status of the condition, or what is condition of the eyeball. So what are the tools available? So main thing is a proper ocular history, or what is a history of injury. Then vision, slit lamp examination, indirect ophthalmoscopy, 90-day lens. Then according to the case, you can have choose any imaging technology like X-ray, ultrasonography, CT, MRI, etc. What are history of injury? A detailed history of traumatic events should be taken. It should aid for examination as well as for investigations. History, if you suspect an intraocular deformity, you should be very careful. Take a detailed history, whether the patient is working in a workshop or quarry or some place industry. And there's a history of hammering metal on metal. That means chisel and hammer. So there's a likelihood of small bit of iron pieces coming from the chisel and going inside. So that history, detailed history should be taken so that you can rule out any intraocular foreign body. And if you suspect a foreign body, what is the composition of intraocular foreign body? Whether it is a metal, iron piece, or plastic, or PVC, or some vegetable matter, that history also should be detailed. History should be taken. And should have a nature of the offending object, how force it was, whether it was a blunt object or a sharp object. If it's a blunt object, it will produce a blunt injury. If it's a sharp object, it will produce a penetrating or perforating injury. And if it is a chemical injury, you should know the agent, what is the agent, what is the concentration, what's the chemical, what's the exact name of the chemical, that all also should be taken. And if it's a bullet or pellet injury with a pistol or something, you should know the velocity also, because it depends upon the velocity, the foreign body, bullet or pellet can even go to the orbit or to the brain. So that history is very, very important. And you should have a past ocular history also. What if possible, a case sheet or from the bystanders or from the spectacle, you should have what is a pre-injury vision, what is any previous ocular problems, any treatment taken, any surgery done, especially cataplasty, RK, etc. And a medical history of diabetes, hypertension, whether the patient is taking any antiplatelet, aspirin, etc. Any allergy to medicine as a routine, and because of injury, you should verify whether tetanus toxoid is taken. And you should ask the fasting whether the patient is going for a surgery under GA. So our aim of exam is rule out or distinguish between open globe injury and closed globe injury. That is the main thing. And second is whether it is a perforating injury or a penetrating injury. These are areas we want to rule out. And we should be very careful to see a ruptured globe injury. History and examination should be very careful. And our ultimate aim is to rule out whether it's a foreign body or not. So that's also very important, especially medical legal cases. The eye examination, there's a comprehensive ophthalmic examination should be done. Later, there can be vitreous hemorrhage, cataract, or corneal edema. Examination will be difficult. And if it is serious injury or perfect injury, minimum examination should be done. And you can do additional examination later or during the surgery also you can do detailed examination. And the most important thing is in ocular injury, this documentation, the photograph or drawing. That's the most important, because most of the injury patients will be young learning members of the family. So it's an accident. So suddenly they are losing one eye. So Dr. Rupesh Agarwal has already told you what is the importance of documentation, how to upgrade into IGATES and everything. I am happy Dr. Sujithra Institute already started that program. So the documentation is very, very important, not only for research, it is mainly for medical legal cases also. Everything should be documented with the drawing and photograph. That's very important. You can produce in the court also. And vision is also most important. It should be recorded what is the vision preoperatively and previous vision also. That is also for medical legal. It is very important to explain the prognosis and complications. And this is severe lead edema, which may be difficult. You can put a speculum and you have to verify whether it's a PL is there or it is a no PL. So that's a decision making for management also. If patient is using a spectacle, use to what is a refractor, what is power of the glass, etc. And you should have external examination before examining the eye. You should protect the injured eye. And you see the orbital margins, whether there's any crepitance, what is any orbital asymmetry, if there's any black eye, what's the position of the globe, what's the palpebral fissure, if there's any proptosis, inophthalmos, ptosis, all external examination should be done. And you should have a little examination of ocular motility also, compare both eye and if there's any diplopia. But you're very careful if there's a ruptured globe or anything, you don't go more details. Ocular movement may be restricted in a severe hemorrhage, edema, foreign body in the orbit, or injury to the muscle, nerve, or central brain. So you should have at least a confrontation method, take the field also, so you get to send retinally touch on any. So if possible, you have confrontation method, field examination also. If you suspect ocular nerve injury, you can use a red test object. And formal visual field examination should be done later if you suspect a traumatic optic neuropathy. So the orbit also should be examined, or you suspect a orbital injury. Injury can even extend to the brain, PNS, cavernous sinus, optic nerve, etc. So you should go for a CT, MRI, or X-ray. Orbital fractures can be medial wall, floor, or blowout fractures. So you should take an X-ray. Inspection should be done for inophthalmos and proptosis, and should have palpation to see if there's any fracture of the bone or emphysema. And lid should have a detailed examination, very any periocular ecchymosis or ptosis. The anti-segment examination mainly cornea is staining with the fluorescent and cobalt. We are routinely doing to corneal aberration or injury. A full thickness laceration, you can do a serial test to find out fluorescence in the antechamber. Conjunctiva and sclera are also important because a severe injury of the conjunctiva behind the conjunctival subpineal hemorrhage, there can be scleral involvement also. So you have to see the lower and upper fornix also for any foreign body. If possible, avert the upper lid and see any foreign body in the upper palpebral conjunctiva. In severe subpineal hemorrhage, especially bullous subpineal hemorrhage, there is a chance of scleral rupture. You have to explore whether there is any scleral tear. Antechamber examination will be very important because shallow antechamber will be due to ocular laceration. Localized shallowing can be due to choroidal hemorrhage and retinal detachment. And deep antechamber will be seen in a posterior scleral rupture, traumatic iritis, uveitis, and severe hyphema. Evaluation of the pupil is important, especially in head injury and comatose patient. The size, whether it is dilator, it can be happen in the head injury or Turner palsy. In spindle pupillae, there can be traumatic mydriasis. You have to distinguish between that. And configuration of the iris and pupil, especially iododialysis, iris injury, and vitreous collapse also should be examined. And pupil symmetry or asymmetry, especially RAPD, should be tested, especially in optic nerve, retina, and macula injuries. If the irregular pupil will be seen in a sphincter tear like this, and iododialysis, the pupil will be D-shaped, and iris contour will be different in a perforating injury with a foreign body. So severe hyphema will be seen in an angle, suspected angle recession. And if possible, if patient allows, you can do a gonioscopy to see any foreign body in the angle also. Examination of the lens is most important because there can be traumatic cataract, the lens will be cloudy, the direct or indirect trauma. There can be chance of subluxation or dislocation of the lens also, can be rupture of the lens and lens matter in the antechamber cortex, or you got to especially see whether it is in the antechamber. Intraocular pressure, if the condition allows, you can do, you should record the intraocular pressure with the NCT or applanation. Low intraocular pressure is usually seen in occult rupture globe, traumatic iritis, cyclodialysis, ciliary body shutdown, retinal detachment, etc. And the elevated intraocular pressure is seen in hyphema and severe lens injury. Examination of the posterior segment is very important. Earliest examination should be done with the indirect ophthalmoscope. Later, the media become clarity. Media clarity will be lost due to cataract or vitreous hemorrhage. Open globe injury, you should be very careful using a scleral depressor. If you are using a mydriatic, it should be documented because in a head injury cases, that is very important. And blend trauma, multiple posterior segment abnormalities will be seen. With this examination, also important to rule out any intraocular foreign body, whether any hemorrhage or endophthalmitis. Presence of RBC shows there is a vitreous hemorrhage, and any demonstration of WBC in the vitreous, that means early sign of early endophthalmitis. Examination of the retina with the indirect ophthalmoscope, you should document, if possible, document it with the fundus camera also. Berlin's edema, retinal holes, retinal tear, retinal dialysis, choroidal rupture, choroidal detachment, all these can happen in a severe blend injury. Optic nerve examination is also important to rule out any traumatic optic neuropathy. That this condition, whether swelling, hemorrhage, color, clarity, margins, elevation, cup, etc., should be examined. What are the diagnostic imaging studies available? So in all trauma, depends upon the condition, you can choose X-ray, ultrasonography, CT scan, MRI. Appropriate combination of techniques should be used, especially it is more important in medical legal cases, and it is important to rule out any intraocular foreign body. Plain X-ray, limited use, it is cost effective. Advantage, metallic foreign body in the eye and orbit can be very well seen. Fracture of the orbital wall and skull can be very well seen, but some limitations. Localization of foreign body may be difficult, and radiolucent foreign body like glass, plastic may not be seen in the X-ray, and it will be difficult to diagnose orbitocranial injuries also. Ultrasonography is the second choice. Advantages, you can diagnose the vitreous hemorrhage and retinal detachment, and radiolucent intraocular foreign body can be detected, especially in the anterior part of the eyeball, and the position of the lens can be assessed. So that will, ultrasonography will help for the planning of the primary repair. And equipment is transportable. If the patient is comatose or ICU, you can take the ultrasound to the ICU and take the examination. But the limitations are foreign body deep in the orbit will be difficult. It will be difficult to do ultrasonography in open globe ocular injuries and extraocular muscle injury. And pure detector scleral rupture with ultrasonography and limited view of optic nerve or bulbar structures. So another choice is CT scan, that is the imaging study of choice. Advantage, extent of orbital wall fractures can be detected. Define soft tissue of orbit and retinal bar space. Define radiolucent foreign bodies, and exact location of foreign body can be done. And examination of the penis and brain also can be done. If you suspect some vascular malformations, you can do a contrast in a CT scan also. CT scan, the limitations are may miss small foreign body unless you get small sizes. Foreign body may be obscured by artifact, fail to delineate wooden foreign body. That's a problem with the CT scan. So magnetic resonance image or MRI for vascular and intracranial pathology. Advantage, soft tissue delineation is easy. Visualize blood in eye and brain. Excellent posterior fossa visualization or low density objects, vegetable matter, wooden foreign body can be detected. And detection of laceration, even avulsion of optic nerve can be demonstrated by a MRI. Limitations, visualization bone is very poor, so fracture may not be missed. Larger scanning times and cannot be used if metallic foreign body is suspected foreign body, intraocular foreign body metallic. And if the patient is using a cochlear implant or pacemaker, you cannot do MRI. And there's a question of shifting of the foreign body during the procedure also. So what are the tests for orbital fractures? So the choice is plain X-ray. You can have a Vates or occipital mental view, or you can have a Caldwell projection, that is occipital frontal view, or you can do a submental vertex projection, or you can do a right bar left oblique projection. It can be associated with a CT scan examination also. Localization of foreign body, you can with the plain films, Caldwell or lateral view, or the time-world limbal ring, putting a ring around the limbus and taking photos, AP view as well as lateral view, looking straight up and down. That will give a clue whether the foreign body is intraocular, extraocular, or which quadrant it is. So that's a time-world technique we can use. And now with the CT scan, thinnest possible slice for small foreign body, you can localize the exact location of the foreign body. In penetrating injuries, CT is very essential. It will rule out brain damage, intraocular foreign body and orbital foreign body, and rule out intracranial problems. And children, the history will be unreliable. So suspect any foreign body, anything, you should do a CT scan in children. You suspect some foreign body. So coloration testing has only limited use, especially in optic nerve, as the optic nerve function. You can use a Ishira or pseudo isochromatic plates. The red color may appear grayish in a optic nerve injury. Electrophysiology also has some role, especially a patient who cannot communicate or a comatose patient, or evaluation of the post-traumatic eyes also for documentation and research. You can do electrophysiology. ERG is useful for severely injured eye, and VEP will give an estimate of visual potential, especially optic nerve and traumatic optic neuropathy. It also helps you to decision making whether to do a enucleation or secondary reconstruction, especially in a patient with no PL, whether to preserve the eye or not to remove the eye. So that will help ERG and VEP will help you to make a decision making. So thank you very much for the patient hearing. So discussion can be done later or now itself.
Can you start? Thank you, sir, for that extensive talk on management, on evaluation of a patient. So we'll do the discussion at the end. As we have evaluated very well, now we need to do a meticulous suturing and management, especially cases of polytrauma. So I invite Dr. Thomas George to talk on the basics of suturing.
Thank you, Dr. Sudha. Thank you for inviting me for this session. I will be taking you primarily through the biomechanics of suturing. Each is a standalone slide, and I can stop anywhere if time requires me to. As far as the needle is concerned, we have to think of needle as three separate things put together. There's a head of the needle, that is the tip with the cutting edges on the sides, and if care is taken not to hold this part of the needle will stay sharp right through your suturing time. Multiple sutures can be taken. Otherwise, it becomes difficult progressively if you hold the head of the needle. Shaft connects the head to the other business end. That is what holds the thread in place with the needle. Either an eye or nowadays it's a swagged needle where it's seamlessly onto the needle, the thread. The needle head decides the type of track it will form. A round-bodied needle looks very nice to us, but then it has a stretched tissue and it will cause irregular tears as it goes through tissue, whereas a cutting needle actually does a better job of making the tears more regular and predictable. Cutting can be different, but when we have a flat needle like this, it's very easy. This is the typical ophthalmic needle that we use, the spatulated one. It's very easy to turn it slightly and slide it out of the tissue altogether, and it works like a blade also. Does the needle track direction matter? It doesn't, but when we look at it, but the needle typically is thicker than the thread it's carrying. So if you have a track like this, and you tie it like this, the thread can later on shift to this end, which has got a lesser length and loosen the whole thing. Same thing if you have a cutting needle in the other direction, within the tissue, you place the thread here, it will shift here, and hence you need a little more tension than what would just close it at the time of suturing. Think 3-dimension for this. Now, where does the shaft come into the picture? We need the shaft to hold the needle and not the two ends, which are business ends, like I said. So if you have a proposed track like this, where you have equal distance from the wound in the horizontal direction and into the depth, it sounds very good. To get it, you need a half circle, but then the whole needle will be inside tissue. So the other option would be to take a bigger needle, which you can do, and get right across, bigger curve. But what would happen is the two different limbs would be asymmetric. So the way to go around it would be to use a needle and pick up one half of the tissue and consciously go about the other half by tilting the needle and changing the direction of the tip when within tissue. Alternatively, this is much easier. One can pick up the ends and distort the tissue so that you get the needle track as diagonals with approximately the same horizontal and vertical bits of tissue inside. Now, about the thread itself, you have the option of a monofilament. It's smooth, less likely to act like a wick and drag tissues in like a giggly saw would do. But the knots need to be more secure because there's less friction and can slip. The other option would be a braided. It is much stronger because each fiber has a give and does not break easily. And the knot is not likely to slip because there's much better friction. It can drag tissue and cause damage while it goes through tissue, and it can act as a wick post-operatively and allow for stuff to go into the wound and add to the infection possibilities. So a wire media would be to coat the braided suture. That's why we have coated Vicryl. You have a coating that is like an insulation on the braided wire, which gives you a smooth surface, but inside is still braided, giving you advantage of both. Absorbable sutures have another issue that as it absorbs, it loses tension as it degenerates. Also, as it degenerates, it needs to be phagocytosed. And in some patients, you would have an excess of foreign body inflammation causing tissue damage around the suture. So now the three functions of a suture would be to oppose the tissue, compress the tissue adequately till it heals, and resist a deformation of the tissue in the interim. The apposition would be helped by other forces which we can take to our advantage. Like if you have a bevel wound like this, on the surface of the globe, the intraocular pressure pushes the inner bevel in like a valve and adds to the apposition. So you just need to think about just closing this end. This will be closed by the IOP. Similarly, if you have a lid coming on top of layers, like your conjunctival suturing, typically we use that to our advantage as a glaucoma surgeon in trabeculectomy. The lid would give us some amount of apposition and the suture doesn't have to be that strong. There is a need for compression. Why? Because if you have the exact length of suture length to keep it just opposed, the moment you have the slightest deformation or stretch force, it would have a gap in between. So you need to compress. And there are problems that come in with compression, which we need to be aware of while we suture. That is because if you have a thread that you want to stay like this, when you pull on it, it'll try to become like this. So you have something like this, it becomes like this, something like this, it becomes like this. So in other words, the thread would flatten a curved tissue. It would straighten a wound edge as you pull on it and increase tension. In interrupted sutures also, this does matter. The thread inside the tissue has got more resistance than what is on the surface. So the deformation actually is going to happen on the base, more on the surface thread. So if you have a suture like this, it's going to invert when you tighten it. If you put a mattress, again, it would do a deformation like this. A horizontal mattress would evert. Horizontal mattress with the limbs right across would invert. Similarly, if you put a continuous suture, it will flatten the curvature of the surface. It will straighten the wound edge. If you try to suture something like this, it will finally, when you tighten, it's trying to become a straight line. Or if you got uneven depth, it would even make the surface undulated. Now we come to actually the meat of what matters in condylar suturing. It is a compression along the suture line. You have compression like this in this plane maximally, but as you get away from the suture, the force that is opposing comes down. So there's a limit. So about maximum tension that you can put on suture would give you around a 45-degree triangle of compressive area. So it decreases as your distance from the suture increases. For a given wound, if you put sutures like this, you can increase the compression by increasing the tension and flattening out these triangles of compressive forces. But a tissue this wide will have to become a tissue this small. It gets deformed. That is an issue when you think of astigmatism. Other option is to increase the number of sutures. Increase the number of sutures also would cause less deformation. So ideally, we should be aiming at sutures that are long also would give us better compression, but ideally we should be aiming at more number of sutures which are not very long, so that we take a balance between the compression and the deformation. Deformation also would affect vision in terms of astigmatism. When we put continuous sutures, that sounds very good, and most of us love continuous sutures because there's only one knot left at the end of it. But there are the issues here. If you put a continuous suture like this, starting from beyond the wound, there is no problem. But a suture like this, the actual end of the wound is outside the continuous suture, and that area can gape because there's no compression at this point. So you need to go beyond the continuous. Also, you need a fair amount of skill to get the continuous suture to have even tension right across the wound. So if somebody puts a suture like this, with one side going too much into the tissue, and thereby this one limb is too long, that area's tension is less than the sides, and that area is going to give. It can gape right under the longest bite of the continuous suture. There's one more issue with continuous suture. That is, if you put sutures like this, you've got these threads on the surface as diagonals. A diagonal will have a vector in this direction also. So it would tend to push, this suture would tend to push the upper part of tissue towards the left side and the lower part towards the right side. Any whichever way you would have vectors like this if you put sutures. And there's a way out again. That is outer sutures. So you put one set of sutures in one direction and you put a similar one coming back, so that now you got one vector this way, one vector this way. It cancels out mostly because the distance between the two is very little. The deformation possible is very little. And finally, you tie up at one corner. So that's the reason why you find keratoplasty sutures going right around twice, because you're creating a suture when they do a continuous suture, that is. Postoperative inflammation can also affect your closure. And this is typically with absorbable materials because you start off like this, you have tissue being lost around it because of inflammation. The suture now becomes loose. It's fairly easy to understand. So that has to be looked at post-operatively. It can happen with monofilament also, but more often with absorbers. How many sutures do I need to close a cornea? Because the cornea is part of a sphere. You have the hinge flap, you have an outer wound lip and an inner wound lip. And if you have a edge to edge, outer to outer chord of that circle, if it doesn't cut the inside, it cannot open. So this is what we take advantage of with scleral tunnels and phaco incisions and paracentesis. End to end, it's inside the wound, the globe cannot open, but this will open. So now, when we think of sutures, what we are trying to do is to segment this wound so that your cords are lying like this. So you have your first suture here, this segment will not open, this segment will not open with the next suture. So such a wound would require only 3 sutures, but you would put more to limit astigmatism. Minimum is 3 to keep it closed. But if you have a perpendicular wound like this, no amount of sutures can actually make it fully secure. You need air or something inside to add to it till it can stick together. So if you have a perpendicular wound, you need actually an infinite number of sutures. You need some bevel for it to be securely closed. So now I'll just take you through a video because that probably, anyway. So that I don't think my video is working, so I'll stop with it. Thank you.
Can you stop sharing? That was a really researched talk on the biomechanics of suturing. So we'll move on to the discussion part. Andrew, sir. Now, yes. The state of Kerala actually is planning to have a lot of trauma centers in Kerala. So if we are planning a trauma center, what do you think should be the basic minimum criteria, at least for ophthalmic trauma? What should we have, like instruments and how to do the initial examination and casualty? Would you have a separate ophthalmic casualty? Would you prefer that?
So our hospital is a teaching institute, medical college with an emergency department with MD emergency course also. So it's a full-fledged department as far as we are Jubilee is concerned. So we have everything in the emergency department, all specialty service also available with a 24 hours working operation theater, ultrasonography, CTA, all attached to the emergency department. So for us, it is not a problem. So everything is available because it is a teaching medical college with MD degree in emergency medicine. But as far as ophthalmic hospital is concerned, I think the casualty or emergency department should have at least everything for a minimum requirement for a suturing and care of a patient with at least with a small Indian microscope, with a minor operation theater. Everything should be there in the casualty of the ophthalmic department. So everything can be done minimum, because nowadays patients are not willing for further admission or anything. So you have to tackle the patient within the patient comes and he has to go back also. Most of the patients. So that way you have a small theater set up in the emergency department with the slit lamp, small microscope. Indian microscope are also available. So in the major cases, of course, you have to admit the patient and you have planned surgery next day or the night or whatever, depends upon the condition. So that's where. So as far as we are concerned, our department is full-fledged with everything.
So Dr. Mehul, you would like to add?
Yeah, one point about suturing. First of all, I think the intraocular tissue are being projected. The debridement will be most important part before suturing. It is not only the suturing, it is the debridement and associated finding like hyphema, blood clots, iris, those should be tackled. Number two, regarding this ophthalmic trauma setup, I think that is the proposal of IGATES integrated services. We should have one integrating person who can integrate for emergency services and all other departments of the ophthalmology, and they can coordinate, but that person will be coordinating about the retina, cornea, glaucoma or plastic surgery or corneal services to integrate the trauma. That is the proposed trauma coordinator for each and every hospital.
So I'm sorry.
Yeah. Can I add?
Yeah, sure.
Yeah. Actually, Dr. Thomas George, it was a very excellent talk. I mean, very well illustrated and very well, all your illustrations were beautiful. But one small thing I wanted to add is in this continuous sutures, actually one problem is that when you remove the suture, the exteriorized part tends to go through the wound track. So the chances of infection, I think, while suture removal could be higher in continuous sutures.
True, continuous suture is just convenience. I would also personally prefer interrupted sutures.
Thank you.
Okay, before we go on to that, when you get an open wound and you're suspecting an open wound, what exact precautions would you take? Because our main problem is that we should not have an ocular tissue prolapse. So how exactly would you recommend to your postgraduate students how they should examine this case? Gently, what instrument and what can you do? Would you do it under GA? Andrew, sir?
What do you mean local or GA? That's all depends upon the patient. And the condition of the eye also. If it's a small injury and small corneal thing, I think you can do under local. There's no problem with the periorbital block or even without block also. Or some sedation also you can give. So giving a GA will be difficult in an emergency case. You have to wait also. So patient may not be willing for that also. So if there's a major injury involved in the posterior segment and everything, of course you should have a GA. That is essential. So this all depends upon the individual case and individual situation also, and the cooperation of the patient also. So local anesthesia, sometimes you can do a periorbital block also. So this all depends upon the condition of the patient, condition of the cooperation of the patient. Everything should be taken into consideration.
No, what examination part, yeah. Yeah, Dr. Thomas?
Yeah, Andrew, sir, actually for ocular trauma cases, how long can we wait? Like many times I have seen that these cases come at odd hours, and it's sometimes the junior doctors who manage it. And the results are not always very good, obviously, because ocular trauma is much more complex than a routine surgery. So in many institutes, even in my parent institute, they used to operate the patients on the next day.
I fully agree. So it should be done with a senior surgeon. So especially trauma should be done by a senior surgeon. I have been in Angamali for 18 years. But that time also the first aid or minimum things will be done by the duty doctor. And most of the cases, if it is very severe, the consultant will come the night. Otherwise, we give the first aid and keep the eye with the antibiotic and pardon. But next day, the senior doctor will come and operate in the main theater. So that's the ideal thing. Usually also we are following the same system. Unless it is a very severe thing, we will do immediately. Otherwise, next day we will do all investigations, and because documentation also important, investigation also important, medical legal case. So it should be done by a senior surgeon as far as possible. That is a very important. Very minor injury or something the juniors can do. Otherwise, serious injury should be done by a senior surgeon, and you can elective as planned elective surgery. Of course, you should not wait too much also. So then also a question will come, especially medical legal cases. The advocates in the court, they will argue that the delay or infection was due to the delay in the operation also. So that also should be there. But something should be done and care should be given to the patient. So allegations should not come. That's why. So all the precaution, all the treatment should be started with antibiotic, and you have to explain to the patient and bystander also. We started the antibiotic, systemic and local and everything. So we'll do all investigations, X-ray, CT or MRI, and yesterday we do a plan test. So patients should not feel that care has not been given also. So allegations should not come also. So it all depends upon those who are handling the junior doctors or who are taking the duty should properly explain to the patient and bystanders also.
So then may I say something?
Exactly. Dr. Grover, I think, should comment on this.
Yes.
I think I totally agree with George that doing the surgery in your routine setup with your routine staff, with your best microscope is very desirable. Although it has been shown that delay beyond 24 hours certainly impacts the results. So if you have a possibility of doing it within the shortest possible time, 16, 18, 20, 24 hours, rather than doing it within 1 hour or 2 hours, with a better support system and a better instrumentation, then you should wait and do it at by the most expert surgeon, because primary trauma repair is the opportunity to do the best for the patient. No secondary repair in any trauma can do as much as a primary trauma repair can do good quality primary trauma. So quality is equally important, although the prime should not be prolonged beyond 24 hours as per the data so far available in publication. The second comment was with regard to the trauma centers. I think for our hospitals like ours, where we get a lot of multi-system trauma and polytrauma, a coordination with other specialties and making sure that the systemic condition is stabilized also becomes very important. So that takes precedence, the general condition, restoration of the vitals, etc., etc. And once that is done, then you have to coordinate with other specialties. And within ophthalmology, it has become increasingly important in all centers to have one person designated as nodal person, as Dr. Mehul was saying, because he can then at least ensure that whatever specialties need to be involved are involved. If VR surgeon needs to be present for the surgery at that stage or at a later stage, the coordination is done. And also, if this ensures that the data is properly uploaded, if you are part of IGATES or at least recorded very well in your systems, when there is a nodal officer who coordinates these things within his own specialty with different subspecialties and with the other specialties in a polytrauma.
And I suppose they would also be basically for counseling the patient also regarding his prognosis. They might be of great help, such officers.
Yes, because they are dealing with these problems ever so often. So a nodal officer need not be devoted only to trauma. He could be a VR surgeon, he could be an oculoplastic surgeon. So he takes care of one aspect, but he's also the nodal officer for all trauma, and he coordinates other aspects with the other subspecialties.
So in case if it's not a good center and they would like to refer to a place, would you recommend a basic suturing before that, or would you, especially the open globe injury, would you recommend that, or would you recommend it, okay, send it and let them do it?
If a referral is possible within a few hours and the distances are not very great, then it may be desirable for everything to be done in ideal facilities as the primary repair. But if there is a compromise of too much time involved, if it is going to take 1 or 2 days for him to get to a tertiary care center, then it might be desirable to do at least the basic repair before sending the patient over.
Yeah, Ashok, I would just like to add that I think India is training excellent ophthalmologists, whether it is a diploma in ophthalmology, DNB, or I think the basic wound repair, according to me, wherever it happened, it should be done immediately with all the precautions. I don't think anybody is operating without microscope now. And I think if they are operating, we have to make sure as a society that they're not reprimanded, at least trained, and make sure they do the proper job. So I think a recommendation will be to do the wound repair wherever it is. A lot of times in the villages, they are afraid of medical legal case and not that they don't have facility. And they just want to wash their hands because sometimes they are arrogant or violent staff, the patients and relatives. So I think the main thing will be, I think we have to do, I think Dr. Srini wrote to me about what she's doing for public awareness. So we have to also create awareness that once an injury happens, it's in whatever you can call it, nature or God's hand, and you can't, fight with the doctor that a vision has come or not come. So I think something we have to protect our own junior most ophthalmologists practicing in the remotest village and recommend to do the wound repair and then send. And Ferenc Kuhn nowadays has changed this theory. The second intervention should be done in 6 days or 100 hours. And that's important, I think, so that whatever we are talking about maximizing vision. So I think reducing the trauma effects and maximizing the vision will be within 6 days. And that's what now I'm doing for the last 3 years.
So in ideal circumstances, yes, you can refer, but in India, maybe more appropriate would be to do the management, at least for the medical legal issues.
No, but we have to protect them from the medical legal issues. So one is a medical legal cell. Second is giving the strength to the doctor. So he also should have something like the rapid whatever force the police has. Similarly, when an injury comes, I think we should have somewhere to be represented to the state society saying that there's an injury case I'm seeing and I'm going to do this, so that you also reassure the doctor and whatever precautions, and he can tell that the patients are violent or whatever, and you have to convince them. Recently, 3 days back, one of my fellow doctors who trained by me 10, 15 years back, he called, he said he has done surgery and they don't want to come for an opinion, and he's trying to convince the patients and relative they are already threatened him, they will take him to medical legal and all. But I think that's where you develop a rapport, particularly with the patient when they have injury. So they will think you're great and everything, but I think they will also anticipate what they will do if you don't get vision.
So just nearing the end of the session, I just want
Sudha, one question to Thomas George for the lot of juniors attending. Choice of suture for cornea, whether 80 or 10-0. Lid, what is the suture you prefer? And for sclera, what suture you prefer? Thomas George, 1 minute. Can you, because juniors are attending.
Cornea, we are bothered about astigmatism a lot, and we need only the tension of a 10-0. So 10-0 nylon monofilament would be what I would prefer on a spatulated needle, so that it would be least traumatic to the cornea. But sclera at 10-0 tensile strength is not enough. So you may need to go for an 8-0. And sclera, because typically is going to be covered by conjunctiva, a braided 8-0 suture also is okay, not necessarily nylon alone. Both are fine, but the nylon knot is more difficult to make when you're going deeper and deeper into sclera as you go after a rupture. So I would prefer a 10-0 nylon for cornea. Conjunctiva also, I would prefer a 10-0 because I don't like braided sutures on the surface, and though vicryl will be okay. And for sclera, it would be an 8-0 braided or non-braided is okay there. Non-absorbable for sclera.
Lid suturing.
Lid, the conjunctival side should have an absorbable suture where the knot is within the tissue. So the posterior lamella should be done with vicryl, and the anterior lamella can be done with monofilament or silk. 8-0 would be what I would prefer. And all knots at the lid margin should be on the lash end at least. It should not be rubbing on the cornea post-operative.
Sir, can we use vicryl for sclera? Sir, can we use vicryl?
No, it should be non-absorbable.
No is my answer. Vicryl loses tensile strength in 2 weeks. Sclera will not have healed in 2 weeks. And you won't know that it's not healed in 2 weeks because conjunctiva has healed over it.
Okay.
For canaliculus repair, which one you prefer? That's a wide question.
I think we'll be talking about Dr. Grover in the
Specifics are coming in the next session.
Okay.
So over, thank you all for the session, being there in the session. Over to Dr. Jyoti.
Thank you, Sudha.
Now we come to the, thank you all. Now we come to the much anticipated talk of the CME. We have two very senior and renowned speakers for us today for keynote addresses. I call upon Dr. Sinha, Associate Professor, Government Medical College, Thrissur, to chair the session. Over to Dr. Sinha.
Thank you, Dr. Jyoti. Very good morning to all. Welcome to this session of keynotes. Today, we are very lucky to have two eminent personalities of Indian ophthalmology to share their experiences and ideas. That is Dr. A.K. Grover and Dr. S. Natarajan. Let me first invite the Surya Jyotis of Indian ophthalmology, none other than Padma Shri Professor Dr. S. Natarajan. Warm welcome, sir. I know the name itself is more than enough, but let me introduce him formally. Let me share my screen. Professor Dr. S. Natarajan, one of the pioneers of VR surgery in India, an authority of VR surgery in the world. Sir is a third generation ophthalmologist, son of late Professor Dr. N.S. Sundaram and grandson of late Dr. Nataraj Pillai, who were respected ophthalmologists in Tamil Nadu. He has performed over 60,000 VR surgeries, trained more than 70 VR surgeons across the globe. And in 2013, he was awarded with Padma Shri. In 2016, he was awarded Meritorious Service by Government of Jammu and Kashmir for performing 47 VR surgeries in 2.5 days to cure the victims of pellet gun firings. He holds many world records. He is immediate past president of International Ocular Trauma Society, immediate past president of Ocular Trauma Society of India, and he is representative of AEOS, ICO General Assembly, and he is president of Asia Pacific Ophthalmic Trauma Society, and he is currently the managing trustee and secretary of Aditya Jyoth Research Foundation Institute, and he holds many other positions. Very sorry, I don't have time to go through all this. And warm welcome, sir. I'm very privileged to invite him to deliver his keynote address, Recent Advances in the Management of Open Globe Injury. Over to you, sir.
Thank you. Thanks a lot for the Dr. Sinu. And I think I'm happy always to talk on the recent advances in the management of open globe injury. Can I have my share screen of? Yeah, okay. So you can see my screen now?
Yes, yes, sir. Perfect.
Yes. So management of open globe injury, intraocular foreign body, and terrible trauma. And I always said the books have been written following the trauma happened. So it's not that we know before how the trauma is going to happen. That's why I saw in the first talk where history is very important, and that's what I keep spending time in teaching the all my team, the optometrists. So we have created like unit-wise, so everybody is trained. I also have my own trauma farm for the last 2 decades. We are filling it up, and idea is to find out. And I started that eye injury registry along with the World Eye Injury Registry with the Ferenc School maybe in the 90s, but somehow didn't pick up. I'm glad now you heard Dr. Rupesh Agarwal from the airports. We have done that. And so the main problem with the trauma is a retained intraocular foreign body, which occurs in 5 to 40% of all penetrating eye injury. And these injuries tend to occur more commonly in young and frequently carrying good prognosis with timely intervention. That's what important matter is the timely intervention. So wherever the trauma happens, I think we have to create centers nearby so that they can be referred, and also give them support for both the psychological management of the patient and the family, as well as the medical legal support. And overall, 20/40 or 6/12 greater visual acuity can be expected in 71% of the cases. And 18% of the posterior segment trauma consists of IOB. It represents a true emergency. Metallic could be magnetic or non-magnetic, like iron, lead, silver, gold, etc. And 70% is usually magnetic and could be non-metallic also, like cilia, caterpillar, hair, nylon line, etc. So indication for removal of intraocular foreign body: persistent inflammation, mechanical damage like retinal tears, retinal detachment, reactive foreign body like copper, iron, and definitely the traumatic endophthalmitis. So in a road traffic accident or an accident happening in the village or in the agricultural background, we have to keep highly suspicion of a multi-organism infection, and that's what we have to be, so that we can treat them. So removal of intraocular foreign body, when to attempt removal. Majority of the intraocular foreign body should be removed on an emergency basis because there's a risk of endophthalmitis. It becomes increasingly difficult. Fortunately, when I was started my vitrectomies in '84, we could see patients coming late with fibrovascular membrane, organized vitreous hemorrhage, retinal detachment, incarcerated retina, and intraocular foreign body. I'm glad to say that nowadays every city, every town has a vitreoretinal surgeon. It's unfortunately or fortunately, vitreoretinal surgeons play a major role most of the time to restore vision for these injury patients, except if the trauma, because trauma does not understand the compartment of anterior segment, cornea, lens, and vitreous, everything. So whatever happens in front of the lens, probably the anterior segment, but still you have to keep an eye on the posterior segment, evaluate the patient. So the first step is to, as I commented also, initial repair of wound, like corneal sclerosis. We had an excellent discussion on that. And primary wound closure is essential to restore structural integrity. So I always suggest to all the juniors, and according to me, the senior most surgeon in the department should do the wound repair and the surgery as an example. Not that every time it's possible, right? Because of my travel, but I love to do that. The reason is where the junior most surgeon may not understand the anatomy because already the anatomy is distorted. The planes are they're distorted by blood, and sometimes the lens capsule stained with the blood looks like retina. So that is why generally whatever I remove, I send it for histopathology to know what you have removed. So I suggest this second step, like 2-step, where you do the second repair in 6 days. Earlier it was 2 weeks, and Stephen Ryan worked in 1983, I think, and mentioned that if you wait for 70 days, the eye is almost inoperable. And then those days they were waiting long because even for a vitreous hemorrhage, they were waiting in 70s for 1 year and 6 months and all. And now we have come to 6 days to repair. So advantages of not delaying, advantage of doing a 2-step approach is in the first day, if you have, there's a leaking wound which can cause hypertony. Wound, actually, if you don't have a good wound healing, again, a VR surgery, when you would put a trocar cannula, it will again leak the wound. So if you wait for this was the old principle that wait for 10 to 14 days for spontaneous PVD. But nowadays we don't want to wait because we have advanced technology, and that's why you need an experienced surgeon to do the posterior vitreous separation while doing vitrectomy. And if you do too early, there's a UVL congestion, and that can produce intraocular hemorrhage. And intraocular location of foreign body. So this is all based on the various history. 61% in vitreous, 15% in the anterior chamber, 14% in retina, 8% in lens, and 5% in subretinal space. And these are the cornea is the front, 65%. You can see evolution. All the eyes in the like frog and elephant or everything was in the front. And now it's come into, and we have an orbit to protect, and that's where so that the eye is pretty. Still, you have 65% of the entrance site is cornea, 25% is sclera, and limbus 10%. So clinical management definitely depends on first is history, and because the reason of a history is to know the knowledge and composition and size and accurate localization, and that for that you got to develop an excellent clinical examination. So I think I remember, don't as a retina surgeon just go into the eye and see only the retina. Start from the eyebrow, eyelid, then conjunctiva, cornea. The idea is you have to have a SOP to make sure you examine and don't miss anything. Don't take it for granted because many times where there is you may not know there's a fine particle has gone in, and we have seen patients like that, and patient may come with reticulosis bulbi a few months later. So that's why history is very important, and delineation of the extent of ocular and orbital trauma, and decision regarding removal of foreign body or leaving it alone. And again, it will depend on the foreign body, it will depend on the location and the surgeon too. So preoperative evaluation, all open globe must harbor a high suspicion of intraocular foreign body, especially in root traffic accident, and also keeping in mind the risk of endophthalmitis. The way to go, again, I'm repeatedly telling detailed history. In spite of practicing vitreoretinal surgery and ophthalmology for 39 years, I still love to take detailed history. And I keep teaching them how to ask the relevant question. When you ask something, they will keep on explaining. But you got to have the relevant question, and then they will give the relevant answer. So examination and answer lead test. So localization of foreign body, clinical examination, including, as I said, right from the eyebrow to eyelid, double version of the eyelid, gonioscopy, locate any foreign body in the angle, indirect ophthalmoscopy, focal corneal bedewing, and biomicroscopically visible corneal, lenticular, or vitreous tract. And as you see, the arrow which you see here. And the answer rate test, the simple, in India, still there's the role of X-ray, plain X-ray, where you can at least find radiopaque foreign body, but not all. And I think there have been some medical cases where they have not done X-ray and they have been punished. So I think as a basic, even in a village, I think X-ray is available. You don't have to do the advanced technology and ultrasound biomicroscopy and wherever relevant CT, MRI, and electrophysiological test, for which they can go to the tertiary care. So here again, classified the foreign body depending on well visualized and poorly visualized. You can have the intravitreal magnet, external magnet. There is a non-magnetical, you have the forceps, and in magnetic you have if it are very rare, I think long time, I have not used the rarer magnet as a transscleral trapdoor, and non-magnetic, where again, it is only if it is in the sclera, and that too, where you can definitely look. Because if you open the wrong place, the sclera, you may not find the foreign body, and you will be traumatizing more. And I want to say there was a small wire which went to in a patient's eye, and they went to KM hospital. I think the resident tried, still the foreign body was visible by the time that's the wire. And I think by the time the resident tried, I think probably the wire went inside and we couldn't see, it was in the angle. And then it was referred to us, and Dr. Sachin, who was a glaucoma doctor and a cataract surgeon, was trying that surgery, and still he could not locate. So he called me. I just tried for 5 minutes. So I always said there's no trial and error. So I said, I'm not able to locate. So I see better we should send to a center where my endoscope did not work. So I said we should send to Dr. Rajiv Reddy and L.V. Prasad, and he has done that. And I hope we should publish that together. The reason why I'm saying this is, in spite of the best experience, you know there's a foreign body and you can't locate. And I remember once I thought the foreign body was intraocular. Then we tried, myself and Dr. Rupali Sinha, the plastic surgeon, that's about 10 years back. The CT scan shows foreign body, but I'm not able to see the foreign body under GA, and we tried. And then again, we closed the wound and then sent the patient again for a CT scan. And again, we saw a foreign body. Then luckily we decided it looks like it was a borderline, and it was extraocular. And I think it was in the orbit, even though the CT gave a report almost it was on the sclera. So again, Rupali removed it from the orbit. Luckily, I didn't do an intervention. But again, we had to do it because with all our clinical judgment, that's why I think there is a recent medical case. If there is a negligence, the doctor can be punished. But if there is an error in medical judgment, the surgeon is actually not punished. So I think you have to keep the records properly so that the patient and the relatives understand what you're doing. So again, instrumentation, you need an entire gamut of external magnet, a rare earth magnet, and you can see this is the external magnet. That's an electromagnet. I actually sometimes magnetize the forceps, and you can also have the diamond coated foreign body forceps called the maximum forceps from Shah. This when we had a faculty from Dr. Stornikov from Russia, 92, I got it. Almost opens 12 to 13 millimeters, so that you can catch large irregular foreign bodies. And this is again there are reports that you can use ureter forceps. I have used ENT forceps to remove in a multi-specialty hospital like Hinduja Hospital. And this I also designed where I introduced suction, because in 84, when I was doing a vitrectomy for intraocular foreign body, I was removing a glass foreign body. I was removing it in the pars plana, and suddenly it slipped and slashed the macula. And I think that was the end of the vision part of it, which is terrible. So I always remember that, and I said, how do I do that? So nowadays I use viscoelastic. Over that I use PFCL, and then I attempt the removal, so that even if it slips, and then you have a suction to hold it and make sure that the glass foreign body does not slip, and then also make the incision of the scleral wound large enough. Earlier days in 80s, we were worried about making a large scleral wound because there's a risk of retinal dialysis. Even now it is there, but we can do thorough vitreous-based excision. And I'm glad my colleague Dr. Manoj and Dr. Maya Shanmugam designed this, the claw, a novel intraocular foreign body removal forceps, particularly to remove the pellets, which I did it in Kashmir for the 5 months in 2016, following Burhan Wani's killing. This is you need to perform a good vitrectomy, identify the foreign body, and then the rest of the vitreoretinal gamut we have to do. So if it is a magnetic intraocular foreign body, if it's visualized, you can use that. And then we also use perfluorocarbon liquid as a third hand. Some foreign bodies float in the PFCL, some will not, it will sink. So if you can't lift the foreign body, particularly even the glass or the intraocular lens, I use the viscoelastic to lift the intraocular lens or the glass foreign body, and then beneath that foreign body I would inject the PFCL so that it will slowly fill it up. And if you fill it up too much, the meniscus will be like this, the foreign body will go here, and again you will not see. And if you attempt more, it will push against the retina and have problem. So if it is a heavy foreign body, PFCL will not have a role. And again, you may have to do lensectomy. So I always suggest we can do a secondary intraocular lens. You don't have to do a cataract with intraocular lens at the same time. And intraocular foreign body is more difficult, more hazardous because of the risk of retinal detachment. And if intraocular foreign body can be localized by indirect ophthalmoscopy, then it can be removed by transcleral approach. And transcleral is almost 1% of my surgery. Most of the time, 99.5% we do vitrectomy. So here I'll show you the three vascular vitrectomy being done for intraocular foreign body removal. So this you can see the corneal wound repair done. And I should say that this is a special forceps which is used, and I make a 12 o'clock incision. Is again to minimize the trauma of surgery also, and minimize and maximizing the vision. You can see the 3 ports are there. I have the endoilluminator grasping the foreign body through the 11:1 incision, and the incision is liberal. It's a 4 into 4, something like a polygonal shape, and then you close the scleral wound, connective wound, and then proceed with the vitreous procedure, where you actually make sure that you do a thorough vitreous base excision, and then you can see that the vitreous hemorrhage is cleared, and then as you can see the exit wound almost close to the optic disc. I'm now clearing that area using the retinal brush. So fortunately, these sort of patients can even get 6/9 vision when the optic nerve is healthy and the macula is healthy. And I treat that as a coloboma, choroid, and retina, and then that means around the exit wound, I do the endolaser, and then do a fluid exchange. There is some sort of hemorrhage near the exit wound, and I think if the pellet has gone through the exit, you don't have to do anything, and many times it heals itself. But you need a thorough vitrectomy. And this was another eye where there was a submacular hemorrhage following a pellet injury. We did a combined wound repair was done, and within 6 days we did a cataract with IOL, and then we did a vitrectomy and drained the submacular hemorrhage using the 39 gauge, and you see the silicone oil in the eye, and about the vision was counterfigured because of the corneal distortion. So we can later remove the suture, remove the oil, and also if there's an after cataract, do a membranectomy. So here again, you need the entire intravitreal armamentarium and treatment procedure. So I also have some interesting cases other than the pellet, where this is a 25-year-old gentleman had a fire fracture injury where the vision was PL inaccurate, diagnosed with 2 intraocular foreign body, one in AC and one in retina. So the surgery was planned in 2 sittings. The left eye primary repair, intracameral foreign body removal, intravitreal, septo and banco was given, followed by left eye lens aspiration with the pars plana vitrectomy. So you can see the first one was done, and then second part we are now going and doing the vitreous hemorrhage. So you can see I'm inducing the separation of the PVD and then making a hole in the posterior vitreous surface, and then removing the vitreous hemorrhage. So the vitreous hemorrhage is organized, and then trying to locate. So you need all the ancillary tests to have an idea where the intraocular foreign body will be. So I always recommend a surgical self-education chapter written by Steve Charles. And now in my cutting edge vitreous surgery book by Springers, I have a chapter called Surgical Self-Education, which is what I tell. You should have a game plan like how we play football. You can have your own team with 11 members, and that's what is our team with the surgery and our mental armamentarium. And then you have a game plan to do how to proceed with the vitrectomy and how to localize the foreign body. But the opponent is here is the vitreous and the retina and the foreign body, and that's like the football team, opposite team. So here you located the foreign body, and I'm now removing the pellet. So as I said, there was a pellet in the antechamber which was removed, and with the cataract was done. See now, in spite of that, again it fell. Fortunately, I have not cleared the vitreous hemorrhage, and this is another technique which I introduced and where I presented in the veil vitrectomy, where you do a new technique where the vitreous hemorrhage is not totally removed. I use the forceps within the vitreous hemorrhage so that you don't touch the retina at all when they grasping the foreign body, because it's like a probe. And if you take something, you can see if there's a tissue or like this, and you can catch the retina like that. So better to avoid that. So you could grasp the foreign body within the vitreous hemorrhage. As you see here, we are removing the foreign body. Again, the incision should be liberal, and I close the sclerotomy wound, and then so we are removing the intraocular foreign body. As you see here, this is the pellet which is coming out, and then again using the intracapsular forceps to grasp the foreign body and removing and do the wound closure. And again, the idea is so that it does not, we don't have to make near the limbus or anywhere to remove this foreign body. And now we are proceeding with the rest of the vitreous procedure, like vitreous base excision, clearing the rest of the vitreous hemorrhage, and wherever endo laser required, do the endo laser. And also you should have the, you can see the optic disc and the macula is all right. I'm using a steroid to stain the uncut vitreous, so that the thorough removal of the posterior vitreous is important. And then you can see there is inferiorly some blood clot which is adherent to the retina. So again, you have to be extremely careful, have a less section, high cutting rate, and then remove the vitreous hemorrhage. And you see, I'm now again part of the PVD has not happened, and now the blood clot with the steroid, you can see the posterior vitreous can be separated well. It looks like that's still like a big foreign body, but it's only a clotted vitreous hemorrhage, and clearing the vitreous hemorrhage, and then that's the end of the case. And then after 1 month follow-up, the best corrected left eye was counting finger 1 meter, so you have to plan for a secondary intraocular lens implant. And this is a glass removal of the glass intraocular foreign body from the eye. And I'm trying to say that this was a glass intraocular foreign body was actually incarcerated in the 6 o'clock in the inferior angle. I had a similar patient where the surgery was done and they could not see the foreign body, and the patient came back later with a retinal detachment because the glass foreign body was in the 6 o'clock in the ora serrata, and then that was produced a tear and a retinal detachment. Here we are again we're making the sclerotomy enlarged, and then this is incarcerated in the anterior chamber angle. So you are really dissecting. You should coat the posterior surface of the cornea with the capsule with the viscoelastic, so that you don't damage the glass foreign body. I'm just showing it a little longer. I hope. How many minutes more, madam? You can always tell me accordingly. I will reduce, cut short, fast forward the video. I'm just showing.
No problem, sir. No problem. No problem. Please continue.
Okay. So actually, I'm showing you the struggle of removing the foreign body. Every time I'm keeping in mind there's a risk of this foreign body falling. So you can fill the eye with the PFCL, and then coat the cornea with a viscoelastic, and then you keep judging your sclerotomy. And then I'm actually now will little forward because it takes some time to get it out. So now you see again, I actually kept it back on the iris and re-grasping it, make sure the grasp is good. And that's where you have the tactile feeling. You know, they have glove. I actually wear double glove, but still I have the tactile sensation. So I'm actually developing a tactile sensation using the forceps. That means, what is the meaning? That whatever you're grasping, you have to transmit that whatever you're feeling through the forceps to your hand, to the brain, so that you recognize that whether it's going to slip or not. So I have extended the sclerotomy, and then I'm holding the, opening the this one, and then removing the foreign body. So in spite of extending, and I'm actually probably I should have, looking back, I'm saying that I should have extended a little more, so that since I can do an extensive basic, so you see again it was stuck. So now we'll be saying, now you can see that I had pre-placed suture, and this is the glass foreign body which I've grasped and removed. So this is again a removal of thorn from the management. So this is, I think, done in 92 or something, when I came from Madras to Bombay. And then this was a patient where these sort of eyes were eviscerated when I came, because they think it's a very bad. There was actually a wooden foreign body embedded in the cornea with an endophthalmitis. So I removed the corneal scraping, remove the material. You can see that I'm using the blade and removing the corneal intraocular foreign body. It was stuck, and the patient came almost 10 days later after the injury, because the local doctor also didn't know what to do. So I think that's why I did like what you are doing, CME now through Zoom, thanks to Trishur for so I did CME every Sunday in Maharashtra, and that time, apart from my all the conferences. That's why I love traveling, just to teach them, because I think I remember, that's a joke I want to say, that this was an endophthalmitis. I'm now cutting using the vitreous cutter. When I came and gave in 88, when I had my card vitreoretinal surgeon, one of the GP asked me, "Are you an anorectal surgeon?" Because he didn't understand the definition of vitreoretinal, and he started it's rhyming anorectal. So I am saying is, they didn't know what was vitrectomy, and that is the era, even though it was 88, it was Bombay, the commercial capital of India, but they were all ignorant and unfortunate. But anyhow, I am happy I did that. Every ward in Mumbai, every medical association in Mumbai, whether it was not ophthalmology, I'm telling, the A Ward Medical Association, IMA, this suburban Juhu branch, like that continues. So I did those days I used the Macamar lens, and we didn't have that time in Bombay Hospital the biome. In 90 I started using the biome, and here is an interesting case. 2 months following trauma, he came. He said I was cutting a plant with a thorn, and then he accidentally fell down. He said nothing happened. But 2 months later, he was treated for uveitis, and you can see there is an external wound. And patient said nothing went in the eye. But actually, 13 millimeter thorn is inside the eye. You'll be seeing this was the wound. And when we saw this, I was searching the foreign body inside. I'm again forwarding that. So you can see I'm removing exudative material from the layer after layer is there in the iris. And this was one of the old vitreous foreign body forceps. So I used anterior segment instrument, posterior segment instrument in both back and forth. So you have to be a versatile bimanual, that means ambidextrous surgeon, and that's what you develop, what the right hand and left hand both has to be used. And I'm glad, thankful every day I remember Dr. Bajanath for the training, the wonderful training is given. And world over I tell that I'm a pure Madras snake. So you can see that after clearing the hole, you think the eye looks good, and I thought there's no foreign body. Then I realized the foreign body is in the pars plana, because the ultrasound didn't pick up, because we didn't interpret the thorn foreign body. So you can see now, because of the technology, you can see that this is the tip of the thorn. You would imagine the thorn is like this, and I'm grasping with the forceps like that. So I'm grasping it with a poor illumination. And those days, whatever I see, only I can see, and the rest of the people, this is a thorn where you can see. And then I'm now holding the thorn with the diamond tested Macamar forceps. And all this Bombay Hospital didn't have. That's why I left Bombay Hospital and started Tejot. I took all bad prognosis cases, and I always operate and tell the patient, I operate, you see, thank God. Don't see also, thank God. And there's the risk of phthisis bulbi, the risk of sympathetic ophthalmia. I take informed consent. And you can see that I have to remove. This is a thorn, 13 millimeter thorn. This is what I removed. It's a 13 millimeter. It was inside the eye for 2 months. So anyway, I did everything, and the patient got. And there's another wooden piece I removed in another eye, where you can see this is a wooden piece. So all these chronic patients I did. I'm glad. And this is again a double perforation beyond orbit. So I think don't give up. And this is what I want to recommend. And this is again a metallic foreign body. There's a long case again. I'll just show. Oh, that's the foreign body. So this I enlarged the sclerotomy. You can see the scleral wound. And I think the foreign body was on the edge, and I'm using the rare earth magnet, which is again Indian made. So because I knew that we can't see it in the intravitreal after doing the vitrectomy, that it was there in the pars plana route, and now I'll remove it using the rare earth magnet after dissecting it. You can see that the intraocular foreign body is now with the tip of the rare earth magnet. And then I'm removing it. You can see the water is flowing out. That means ring is flowing out. That means the sclerotomy is quite well wound. And you can see that that's the foreign body which is removed. And then you proceed with the rest of the vitreoretinal procedures. So again, this is post surgery how the eye looks good. And I think almost this patient got 6/6. So there are no PL in some of the eyes which regained. This is one of the 34-year-old woman where the child was playing with the gun, which is called the monkey repelling gun, where they used the pellet again. And you can see they did a surgery in RR Hospital, Delhi, and then they had a recurrent detachment, and then the surgery was done. You can see there is the exit wound, and there is a total retinal detachment. And so you can see I'm trying to repair the retinal detachment, and there was no, they already removed the pellet. So as I think I remember one of the talks they said in the 30-40 years back, the idea was only to do anatomical removal of the foreign body. I remember even the patient would tell, sir, you remove the foreign body in the government ophthalmic hospital, that is success. And even patient was thrilled. He didn't want about vision. So you can see there is an exit wound. I'm doing a large retinal tear was there under the PFCL. I'm doing a laser. It was like a gone case. They said nothing can be done. And I did this. And the patient's husband was working in Uri as a soldier. And I told him, how can you have a gun loaded and kept, your children can play with it? So I think there are a lot of traumas. You can see the silicon, the PFCL bubble under which I'm done the laser, and then I'm doing the clearing of the surface. And this patient got about 3/60. And we have a program called, so this I'm injecting the silicone oil finally. And nowadays all this is automated, and I don't do sutures at all. Many times they keep asking. I give subconjunctival, subtenon silicone oil, the tricot. So this is again on a Christmas day in 2020, a 65-year-old lady played with the grandchild, and then I had this expulsive hemorrhage and no PL to start with. So I'm actually doing a AAC wash, and I'll be showing the drainage of it. I do this suprachoroidal drainage using the trocar. That means what I put it halfway through. It looks like a crude surgery, but you can see the suprachoroidal hemorrhage is being drained. Suprachoroidal hemorrhage, again, 6 days, you may not be able to drain. Depends on the injury. Then I'm making the 3/4 partial vitrectomy. I didn't touch the lens. You can see the blood everywhere in the AC, in the vitreous hemorrhage, then suprachoroidal hemorrhage in the orbit, and the eye was tense. And you can see I'm clearing the vitreous hemorrhage using the PFCL. I'm also using AC maintainer. So I think I'm an aggressive vitreoretinal surgeon, and I make sure that I do everything to clear. And this patient has undergone 4 surgeries now, and you can see there's a conclusion of the first surgery. So I never give up. So to summarize, prognosis in intraocular foreign body case depend on the location and the type of injury, substance involved, and the time of removal, in addition to the type of repair you have done. And the extent of primary damage occurring at the time of initial injury remains a limiting factor for visual outcome. And I always tell, be careful with words, particularly the residents who are seeing the patient after seeing referred by somewhere. You should never give a casual thing, oh, they should have done the suture, or they should have. Never murmur anything in front of the patient, whether you are doing fundus photography, slit lamp photography. The reason is the patient or the relative picks up and they go to the court. So I always want to tell that you should be careful in talking. So never talk in front of the patient or relative, however close they are, they understand. So I think it's important to make sure that you are always maintain the decency and decorum, even if the surgeon has done wrong. So what? I tell the patient also. Sometimes patient fights with me saying, you are supporting the primary. I said, yeah, what do you do? Tell me. Can you undo anything? So best is I don't enter that controversy. I tell them, today I'm seeing you. You are operated last week. You had an injury 1 month back. How can I tell that what happened was wrong and what it was wrong? I said, who told you that to have injury I have done? So same way, you cannot question what has happened. So I support the doctor openly. But not that I'm supporting the mistake of the doctor, but I think you have to always use this word that the first doctor has done whatever. See, if he's having expulsive hemorrhage, and if he's a young surgeon, he will be terribly upset when he's operating. So I think best is to give him confidence and tell them whatever it is. I call the doctor. I've said, this is what I've explained. They may come back to you and they may say that this and that. So make sure you connect the patient in front of the patient so that I will tell them. So I always support, because I said, what is the use of having 39 years experience and not able to support our own colleagues or juniors? Thank you. And thank you, the Trishur Ophthalmic and Dr. Grover, especially because he specifically called and said, Dr. Sudha will invite and you have to say yes. There's no question of no. Thank you, Dr. Ashok, for that. Yes, and we both are friends for again more than for 35 years.
Thank you,
Sir, wonderful eye opener. I listened your talks many times, but it was never this long. So this is the first time I am listening you such a long and elaborative talk.
Yes.
Okay. Thank you very much, sir. That was an excellent and exhaustive presentation. Let me thank you on behalf of TACO and KSOS for accepting our invitation.
Any questions I can answer? I'll wait.
So we'll move on to next talk.
Yeah, sure.
Yes. Next, we have a doyen in the field of oculoplasty and anterior segment surgery. That is none other than Professor Dr. A.K. Grover, the current president of Indian Ocular Trauma Society of India. Again, does not need any introduction. But for formality's sake, let me say a few words. Professor Dr. A.K. Grover, sir pursued his post-graduation from AIIMS, Delhi. He started his professional life in 1984 from Maulana Azad Medical College, New Delhi. His areas of interest include oculoplasty, orbital, lacrimal, periocular, aesthetic surgery, phacoemulsification, and refractive surgery. In 1992, he joined Sir Jagnaram Hospital as a senior consultant, and in that period, he brought the specialty of oculoplastic surgery. Sir founded Vision Eye Care Center, New Delhi in the year 1995. He is past president, All India Ophthalmological Society, past president, Oculoplastic Association of India, president, Asia Pacific Society of Ophthalmic Plastic and Reconstructive Surgery. And it's my privilege to invite Padma Shri Professor Dr. A.K. Grover to deliver his keynote update on orbital trauma and eyelid laceration. Over to you, sir.
Thank you, Dr. Sanamal, for your very kind words. I'm grateful once again to TACO as well as the KSOS for this wonderful seminar and for the opportunity to be here with all of you. I feel like a part of Kerala Society now that now I've already made a few presentations. We'll be making another one 2 weeks from now. And also with my daughter-in-law, my oculoplastic colleague, Dr. Tuja, also being a Keralite, I feel a part of you, all of you. Thank you very much. So I'll be speaking on an update on eyelid and orbital trauma, and it'll go with the theme of what Natarajan said, never give up. So we'll talk about some of the tougher situations since this is an update, and I'll talk about some of the sequelae or deformities that result from eyelid trauma. And then I'll go on in the next 10 minutes to some of the tougher situations in orbital fracture management. So meticulous primary repair is the key to giving the best possible results in an eyelid trauma as well. So learning the right technique of eyelid repair and marginal repair is critical to ensuring good results, which is also helped by the fact that we have a very rich vascular supply on the face. So the deformities that we'll principally concentrate on are marginal misalignments, eyebrow malpositions, traumatic ptosis, and canthal displacements. So marginal misalignments can lead to ectropion, they can lead to entropion or exposure keratopathy and even cause a loss of the eye. However, a simple process of marginal suturing can restore back early, say about a week later, or delayed deformities at the margin. It may require the wound edges to be excised and made fresh again, and the results can be quite dramatic. As you can see, the ectropion here, the entropion occurring here, and the exposed inferior part, all that can be corrected by a good repair. Eyebrow malpositions like these, this one was following bite by a tiger, and following that, after the primary repair, there was a brow deformity like this. You simply revise the wounds, excise the scar tissue, cut the edges and put them together. You can get back an excellent alignment. Traumatic ptosis results when the primary repair has not been able to repair the levator muscle, or there is a nerve associated problems. So assessment is like any other case of ptosis, and based on the amount of ptosis and levator action, you may undertake any of these approaches. But most cases require a levator aponeurosis repair or a sling procedure. However, before any of these procedures is done, it is also important to carry out a good marginal realignment or reattachment, as we'll see in the subsequent slides, before you undertake the ptosis procedure. So in this case, for example, a levator resection was possible, and levator resection resulted in extremely gratifying correction. Canthal deformities are one of the most tough problems to tackle, and these may occur because of soft tissue deformities or naso-orbito-ethmoid fractures in this region. And they may require a number of different techniques to tackle. But one of the important abiding principles in medial canthal reposition is to anchor the medial canthus at the right position on the posterior lacrimal crest behind the sac. It is this deep anchoring which is of vital importance. Here we are using a proline suture to anchor it on the periorbita or periosteum behind the sac at the posterior lacrimal crest, taking a bite through the medial canthal tendon and opposing it. However, many cases require a different approach. Bilateral cases or cases with some other difficulties may require transnasal wiring, which we will see an example of. But in other cases, low profile mini plates are the preferred modality, where small hole plates, either T-shaped or horizontal, drilled with short screws, generally about 4 to 5 millimeter, are important to achieve a good apposition. So once this mini plate is placed on the posterior lacrimal crest after taking care of the bony deformities, you are able to get a good position of the medial canthus. So here a Y to B plasty has been planned, incision given accordingly, with the new canthus representing the position where the new canthus should be the end of the Y. Now we are putting a micro plate of titanium with about a 4 millimeter screw. Sometimes a 5 millimeter screw is needed, and a proline suture has already been passed through the other arm. And once this is done, you can then anchor it to the medial canthal tendon and then tie it with a proline suture, which is a permanent suture, and which would provide you with the right depth and right correction of the medial canthal position. And passing a suture at the junction of Y and V, you can place double arm sutures, take a deeper bite at the same time in order to ensure that this end goes deep rather than this end coming up. And then you can do a good tying after excision of some of the redundant tissue. And this results in an excellent reposition and an excellent correction, as we can see on the first post-op day. This is the position, and now this is what we have created, correcting the horizontal position, correcting the depth, and making sure that your distance from the nose is equal. Another example of Y to V plasty with posterior fixation. You can see this is an example of a traumatic telecanthus with downward displacement. Here, a combination with a Z plasty to take the limb on the, displaced canthus in the lower limb of Z and transposing it to the upper limb works beautifully to take care of the severe downward displacement. So this is an example of a scar which involved the forehead. There was a brow displacement, which was causing, and medial canthus was displaced anteriorly, and there was a telecanthus. So we revised the scar by excision. We placed the medial canthus in its normal deep position, and we realigned the brow in one go. So a repair of this kind can be extremely gratifying. Associated bony deformities with traumatic telecanthus with both sides fracture of the naso-ethmoid region causing severe telecanthus, and bilateral chronic dactylocystitis due to traumatic NLDO was an example where we opened up by a bicoronal approach along with a plastic surgeon, did an open sky dacryocystoidinostomy, passed a transnasal wiring, and we could correct her dacryocystitis as well as her telecanthus well. And she later needed a squint correction. She, of course, had no perception of light in this eye because of traumatic neuropathy, but her life was significantly improved qualitatively by this intervention. Lateral canthal displacements can be even tougher. A displacement like this is a girl who's a doctor now, where we totally detached the lateral canthus, supported the posterior lamina with graft from the hard palate, and we could reposition the lateral canthus in the right position after doing all the detachment and reattaching the lateral canthus at the lateral tubercle. So management of traumatic eyelid deformities requires a wide array of techniques. The effort can help transform lives. I'll go on to the talk on the orbital deformities. Can you see these slides well?
Yes. Yes.
Yep. So I'll talk about the advances or the update on what we do in the management of big orbital defects caused by fractures or by other modalities. So the role of 3D imaging, volume assessment, and patient-specific implants are the new thing that we do in management of orbital defects. So precise restoration of orbital anatomy and precise restoration of the volume as we have measured it is the key to management of orbital defects. So what are the steps if we want to do a precise management of orbital fractures? You need to assess the altered anatomy very well by imaging. And then you need to measure the orbital volume on the normal side and on the abnormal side. 3D imaging and modeling is very important. It helps us to assess the exact defect and to prepare the appropriate patient-specific implant and to choose the correct modality, as we will see. And it is possible to assess the post-operative correction and volume restoration again. So once we have restored back the volume, we can check again whether we have matched the orbital volume of the normal side or not. So a good imaging is important. As you can see, a good coronal imaging shows us where the fracture is and what the dimension anteroposteriorly is. And similarly, the sagittal view, these two are the key. So you can see exactly where the defect is starting and what is the importance, how much is the floor involved. As you can see, how much is the tip and how much is the extent of involvement, which helps us plan things well. Now, whenever we want to have precisely standardized images and to be able to transmit it to others so that they are able to do the 3D imaging and reproduce everything, the DICOM standards for imaging are important, which allow the imaging data to be seamlessly transferred and interpreted between users. So these DICOM standards are well known to radiologists, and they're useful when you want to send your image for somebody to carry out a further assessment. Now, orbital volume assessment by the quantitative methods is become an important part of pre-op evaluation in orbital trauma. So you do a 3D volume surface rendering assisted region of interest computation. How do we do it? You define all the landmarks that are important in determining the position of the orbit from anterior to posterior to lateral to medial, all these superior, inferior. These are all defined, marked out on the software, and the softwares for orbital volume calculation are readily available. So a number of studies have confirmed that you can get a reproducible assessment. And although the normative data in different populations may be different, it is quite safe to utilize normal orbit as a control for management of the disease site. So this is an example of a pre-op increased volume 36, which could be restored to that of the left, which was 32. So this is how you are able to accurately reproduce the volume. So 3D printing and modeling is carried out by those who are specialists in it based on the CT images that you send, and it shows you the exact nature of the fracture, the defect, and you are able to plan further based on that. And then they send you a virtual surgical plan showing you the implant size, implant position as to how it will be fixated, and all the parameters with regard to the holes on this, with regard to where it will be fixated. And these you can alter, you can look at it based on your experience of where you need to fixate, whether you would like to displace the lateral canthus or not. So you can accordingly get it modified, how much you'll be able to push it with the soft tissues in position. All those things you learn gradually. And based on that, you get it modified to the manufacturer. So what is the precise role where you will use these patient-specific implants? You don't need them for all cases. So if there are small hairline fractures like this, so-called white-eyed fracture, which require emergency management, you can see that this is the fracture here. Here you can simply lift off the fracture and you may or may not use an implant. Here we are using a very thin EPTFE implant, or you can use an absorbable implant, and that will do the trick. However, more severe cases may have a buckling of the bones. You can see as compared to this side, there is a buckling and there is a herniation of contents. The size being significant and ocular motility being restricted, it requires an intervention. And this intervention means that you need to precisely see the area of incarceration, make sure that by hand over hand maneuver, you are able to pick off the contents entirely. Now, the older the fracture is, the more difficult this maneuver may become. But you must be able to identify all the dimensions and the extent, anterior, posterior, lateral, inferior, all the of the fracture. And you can see the defect now going through and through into the antrum. So, and then at the end, you should be able to make sure that the force duction test has become negative. And then once you have defined it, if you have an implant which covers this adequately on all sides, that is all that you need. So a MedPOR or an EPTFE implant in a fracture like this would be more than the adequate. And at the end, we check the force duction test again. Larger orbital fractures with huge downward displacement like this, or fractures which combine fracture of the floor with medial wall, are much better tackled with titanium implants, and preformed ones like these are particularly useful. The flatter ones are like these, which you need to shape on your own, and these are easily available, and the people will come readily to your operation theater to make these available to you. So this is a patient with floor and medial wall fracture. You can notice that there is a significant enophthalmos in this patient, and that is because of the large medial wall fracture associated with a floor fracture as well. Now, in this patient, we could put a titanium implant, which must enter up to the ledge, which makes sure that it will cover the floor adequately and make sure that it does not buckle later on. Also, it conforms to the medial curvature on the other side so that the medial and the floor can be done as one single piece. And post-operatively, you can see the enophthalmos is corrected adequately. However, if there are multiple walls involved with near total loss of orbital floor like this, these are the tough cases where patient-specific implants have a particular role. So this was a patient with post-traumatic enophthalmos with huge fractures like this, like lateral wall was displaced and floor was displaced, medial wall was displaced. Now all these needed to be repaired, and we took up the 3D modeling and patient-specific polyethylene ether ketone implant. So this is called a PEEK implant, which is biocompatible, has been used extensively in orthopedics and dental surgery. And this was the virtual surgical plan. And after making sure that we had exposed the floor, lifted up the periosteum, we placed the implant in position. There are these positions where the screws have been fixed. The lateral canthus had to be opened up, and we had to replace the lateral canthus in position. And we could significantly improve as enophthalmos, as you can see. The postoperative image shows the PEEK implant in position, and which has grossly improved the position of the inferior rectus muscle and the globe. This was a 38-year-old male with loss of orbital floor, medial wall following maxillectomy and ethmoidectomy following mucormycosis. So you can see how much globe is displaced down, enophthalmic, and there is a large deformity because of this. So as you can see, this whole ethmoid is missing, the maxilla is missing, and the globe is grossly displaced down. So we made a patient-specific PEEK implant for floor medial wall and placed this. And you can see how much it has helped the patient in positioning his globe at a much better position and correcting his enophthalmos. So this is the appearance of enophthalmos, and this is after the surgery. Again, you can see the significant improvement in the enophthalmos on the right side. So, and the motility also remained good in all directions except upward gaze, where there was a restriction preoperative. To summarize, advantages of 3D printing and patient-specific implants are you are able to mirror the fellow orbit, do a much better preoperative planning, complete walling of defects is possible, and you're able to precisely match the contour and restore the volume more precisely. The PEEK implants as well as the titanium implants can be used. PEEK has the advantage of a very good biocompatibility, good imaging properties, and very good mechanical properties as well, and where the facility is available, many convenient manufacturing processes. However, it requires more advanced technology than usual, cost is higher, and close coordination is needed between surgeon, radiologist, and the technical team. There is a learning curve where you have to fit in things into soft tissues, not just the bone model which the technician helps with. And you have to think of the limitations. You may need intraop, drilling, trimming, shaping. The 3D modeling, volume assessment, and patient-specific implants are important in the orbital fracture management in appropriate cases. Thank you very much. This is from a recent trip to Jaisalmer. Do visit the place. It's beautiful. Thank you, and thank you again for this opportunity. I hope I have been able to cover some of the important aspects in the update.
Thank you very much, sir. That was an enlightening talk on cosmetic oculoplasty with many practical tips that are useful for us also. Let me thank once again for accepting our invitation and for all your support. I think I have two doubts. Dr. Jyoti, can we have a small discussion?
Yes, you can have.
Okay. Sir, I have a doubt, which is that absorbable implant you have used for that hairline fracture of the orbit.
The one that I was using was an EPTFP implant. It's called a Gore-Tex implant, but in India, it is manufactured from Bombay and we get it from them. It is available either as a thin sheet like the one that you saw. This is not an absorbable one, because the limitation of absorbable ones is a relatively higher cost. So these in these small linear fractures, you can do with any implant which just covers that area. So this was an EPTFE or so-called Gore-Tex material, which was manufactured in Bombay. We can get 1 millimeter plates, we can get 2 millimeter plates, all that by requesting the manufacturer.
How much time it will take to reabsorb, absorb? How much time it will remain like that?
This was not an absorbable one, but the absorbable ones take variable time, and there are those that absorb early to those that absorb a little late, so that other tissues have come in instead of that. The newer models that are available, which are used interchangeably with non-absorbable ones, last for a significant period of time for a tissue plate to form there before the absorption takes place. So there are all types available. Only limiting factor is the cost.
Okay, sir. Thank you, sir. And one question to
ask a question, Sinha.
Professor. Okay, madam, you continue.
Yeah. So can these screws and all, are they compatible with MRI? Can you do after this?
Yes, titanium. Yes, you can go ahead. They are not those which have any interference. They are not magnetic. They are not do not interfere with subsequent imaging.
One question to Professor Natarajan, sir. Sir, can you hear me? Professor Natarajan, sir?
I think Grover sir, you can
hello?
Stop sharing.
Yes, sir. Okay, sir.
Grover sir.
Hello, you asked me something?
Yeah, I have stopped sharing.
Okay, sir.
Okay, no, you asked me something?
Yes, sir. In that glass foreign body removal,
yes.
Why couldn't you approach through the same side? You approach through the opposite side, no?
Correct.
You can, yes. What is advantage of that?
No, I think probably we didn't do the UBM that day, that particular patient. That's what I remember. It's about a few years back, and I think it was in the antechamber embedded. So I don't know where to make the incision. And if you make an incision in the sclera, I think the bleeding may be more, and maybe the iris may get disinserted. I thought. So even here, when I was pulling, there was a hyphema was slightly happening. I could see under the microscope, because these were not whatever I saw, it is not recorded properly. So I think it's a good idea to, but I don't know whether anti-segment outside external approach in the same area would have been a good idea. And here at least I knew it was embedded like that, so I knew when I was grasping and pulling it.
Yes,
but one patient, that foreign body I showed iron, which was in the sclera near the sclera. So there I made a incision where it was a part of the limbus, but I used the magnet and it came out, where you don't have to visualize the foreign body, but here you have to visualize the glass foreign body when you're removing.
Okay, sir. Thank you. And another thing, please let us know your thoughts regarding chance of ocular trauma subspecialty for fellowship. What are the chances and what are the advantages?
So I think Dr. Mehul has already trained one of the VR surgeon and ocular trauma fellow, because Dr. Grover was very particular when he was the chairman for that FACO also, that we should have a fellowship. And I think we are trying in my place. If we don't have a separate, the VR surgeon manages most of the trauma, and then whenever oculoplasty needed. But we actually, Dr. Grover has made the curriculum where somebody is doing oculoplasty fellowship or whatever fellowship, and in addition to trauma, I think Rupesh Agarwal is one such person from Shankar Nethralaya, where he was trained only as a trauma fellow. But I think only as a trauma fellow, what Rupesh keeps telling, where Dr. Cesare Forlini was a pole-to-pole surgeon, is not practical, I think. And so Ashok, you are now the current president. And
yeah, I think what is practicable at this moment and what we are trying to do is, we have a curriculum defined by the Ocular Trauma Society of India, and we have designated a fellowship. What we are advocating is that you can take a fellow for any other subspecialty which is related. Say, for example, he's a VR trained person, but he can be trained to have a 6 months additional training with a lot of exposure to ocular trauma cases. So which means that he can then go and become the nodal officer in his institution. In every tertiary hospital, every major eye care hospital should have a trauma nodal officer. So once he goes and joins there with that additional 6 months of ocular trauma fellowship, in addition to say VR fellowship or oculoplastic fellowship, he can then take that role of handling ocular trauma as a nodal person, handling his own specialty, but involving others of other specialties as well. It may not be possible for an ocular trauma fellow to handle all subspecialties, but he should be good at one subspecialty, which becomes his specialty, say, for example, BR or oculoplastics or anterior segment, and he involves others as a nodal officer, as a specially trained person in ocular trauma.
Ashok, we should now proceed with the phaco in ocular trauma, I think. With this concept of the surgeon, for example, he is oculoplastic fellow he is doing under you, and you certify that he is a good plastic surgeon, oculoplastic, ocular trauma training. If you remember, I think that was your own point also and Azhar's point also. You don't have a fellowship, why do you want a phaco exam? But I think to propagate the ophthalmic trauma. Andrew, you have to mute. Andrew, you have to mute. You have to mute.
No.
So once we are able to push this concept of additional 6 months of trauma, then we should be able to, as a second step, go on to phaco in ocular trauma as well.
Good. I think we should start that, I think.
Yeah.
And at least the members, Mehul did a program. Where is Mehul? Mehul?
I think phaco in ocular trauma is a very good idea.
Hi, Rajesh. Good morning.
Welcome, Rajesh.
Rajesh, you should start in AIMS then.
Yeah.
No? No, we want Dr. Grover's point was, and Azad's point was, that somebody should certify that this is you are a cornea fellow, but in addition, you are having an interest in ophthalmic trauma and you are being trained. So that can be comprehensive. That means Dr. Grover gave in the presidential address that that can be a nodal ophthalmologist. That means he's a cornea fellow, but he can arrange the retina, oculoplasty like that. Same way, oculoplasty, he becomes a trauma fellow. So that means he takes care of all the principles of ophthalmic trauma repair.
Yeah, I think only trauma. I don't know how much applicable it will be, but
not only trauma, Rajesh. Not only trauma. What we are telling is, if a civil registrar is working as a cornea surgeon and he is interested in ophthalmic trauma, phaco, as a call tells him as ophthalmic trauma, so he should have some additional 3 months of rotation of all the trauma in the oculoplasty, vitreoretinal rotation.
Maybe 6 months is what we are advocating for ocular trauma exposure, particularly, in addition to his own primary specialty.
Dr. Sinu? Let's wind up the session.
Yeah. We are running short of time. Thank you all. Thank you very much.
Very good at Taskmaster, Dr. Sudha.
Thank you.
Thank you all. Thank you all. Mehul can give a talk during his comments during his talk.
Thank you all. Third session is about special scenarios in ocular trauma. Now I invite Dr. Litika V, Professor Amala Medical College, Thrissur, to chair the session. Over to Dr. Litika.
Good morning. Hope I am audible.
Yes, you're audible.
First of all, let me thank Ksos and TACO for this opportunity to chair the session on special situations in ocular trauma. We have with us 3 very eminent speakers who will be taking us through 3 different topics of equal clinical relevance in our daily day-to-day ophthalmic emergency care. So first, let me introduce our faculty. I'll be doing it back to back. Then we'll go on to our scientific session and the questions will be taken at the end of the session. Let me share my screen. So first, let me introduce our guest faculty. We are indeed very much honored to have with us Dr. Mehul Shah. He is the General Secretary of Optic Trauma Society of India. Sir is the Medical Director of Rashtriya Netralaya, Dahod, and he is basically a vitreoretinal surgeon, alumnus of Shankar Netralaya, with a mind-boggling array of publications and presentations in international journals and CMEs. He has authored 2 books and contributed to 10 chapters in different books. And he is also a reviewer in 11 international journals and on the editorial board of 3 of them. Training, both clinical and surgical training, is a passion for him, and he has been training DNB residents, fellows, optometrists, nurses over so many years. He is the recipient of 26 awards from various fora. So we are indeed very much privileged to have you over, sir, as a faculty, and we really look forward to learning from your vast clinical and academic experience. I extend a very warm welcome to sir to this session. Now moving on to our own host faculty, we have Dr. Biju John. Of course, he needs no introduction to the scientific community of Kerala. He has been in and around for the past 2 decades as a faculty in all our Drishti conferences. He's currently the additional professor and HOD at Government Medical College, Kollam. His area of expertise makes sure that he is a versatile surgeon, equally comfortable with both the anterior and the posterior segment. Today, he'll be talking about intraocular foreign bodies. I welcome Dr. Biju to this session. Next, we have an equally eminent faculty, Dr. Sujithra Haridas. She's professor at Amrita Institute of Medical Sciences, Kochi, with a special interest in oculoplasty and neuroophthalmology. Dr. Sujithra will be enlightening us on the nuances in the management of traumatic optic neuropathy. I welcome her very warmly to this session. So now we can go on to the scientific session. I invite Dr. Mehul Shah for his talk on overview of pediatric trauma. Over to you, sir.
Can I share my screen now?
Yeah, I'll stop sharing.
Thank you, Ksos and Taco, for giving us an opportunity to Ocular Trauma Society of India and particularly to me. Thank you, Dr. Latika, for your kind words. We'll be looking forward to understand about the ocular trauma in pediatric age group, which is very important age group. It is important cause of monocular blindness and having variable outcomes because of comorbidity. Why talking about pediatric ocular trauma is more important is social and economical impact, because child has to live whole life with the blindness. And if we look at in terms of economical burden, out of $77 billion burden of overall blindness, childhood accounts for 28 to 29%. What are the challenges in children? Maintaining optical clarity because of recurrent inflammation and secondary cataracts, comorbidities, difficult assessment of visual acuity, and most important thing is amblyopia, which is making the outcome difficult. So if we want to understand, first we have to go for classification. We have a different discussion about different registry and classification. This is old BETS classification, which we have validated for our approximately 5,000 cases. And this is how we modified. The red part is our newer categories for modification, which has been published and validated in Journal of Trauma. It was combinedly done by our center and Rupesh. So if we understand that, so these terminologies are remaining common, like closed globe contusion, manifestation. If we look at in the entry segment, these are most common sites which you keep seeing: iridodialysis, traumatic dislocation, or subluxation, or osseous ring, maybe IFEMA or traumatic iritis. If we look at the posterior segment, we have different manifestation. In younger children, we may find this Berlin's edema, choroidal rupture, macular hole, or optic nerve avulsion, subeyeloid hemorrhage, and post-traumatic retinal detachment. This is another variety which is very important to understand. This is because of bony fractures. We find the posterior retinopathy, and following treatment, this can be the end result. These all aspects we have published in Indian Journal of Ophthalmology as a closed globe injuries to the children. When we think about open globe injury, they are the wounds. Important is size of the wound, shape of the wound, and location of the wound. That defines the zones. We all understand that what is zone 1, 2, and 3. If it is going 5 millimeter beyond the circle of Tillich's, that can come as a zone 3, then zone 2 and zone 1, which has got different prognostic values. If we look at some innovative techniques, as I said, that debridement is a very important part. It is not only the suturing, and associated findings has to be dealt with. If we make the either AC maintainer or we use the handheld irrigation, then we can debride this part. We can remove this, since this is an injury older than 24 hours. So we try to remove all the uveal tissue using vitrectomy cutter so that my wound remain neat and clean. And again, the hyphema can be stopped. We remove all the hyphema and then make sure the iris chamber is maintained and regular, and there is no connection between the iris tissue and wound. And remaining thing can be taken during the second sitting. We can take care. I was talking about this article has been published in Journal of Eye as a part of IGATES registry. Traumatic cataract is important part which everybody else is coming across. These cataracts in day-to-day practices, and there are certain facts which you need to understand about this. There are various morphologies which has not been described in routine books, because our surgical technique as well as our approach to the cases depends upon the morphology. And if the various morphologies of traumatic cataract, everybody is coming across. These are different morphologies. So we try to connect the morphologies with the surgical technique and visual outcome. In our country, patient may present early or patient may present late to us. If they are coming late, then the surgical technique may differ. If they are coming early, the surgical technique may differ. So we have published the article, Morphology of Traumatic Cataract, Does it play a role in final visual outcome? And it can help us to decide the surgical technique. So these are the one of the case for globe rupture and one is for penetrating. In globe rupture, there is already capsule is ruptured and we can't do anything regarding this. So in children, the things are softer if the case is earlier. If they present early, then we have repaired the wound. During second sitting, we are doing this. It's fairly simple. That is then we can insert the lens, do primary posterior capsulotomy. Insert the lens and doing the primary posterior capsulotomy, that is vital part. If this is penetrating injury, we can see there is an opening in the 6 o'clock, causing the rosette type of cataract. After suturing, there is some vitreous strand towards 6 o'clock. We did the vitrectomy, remove the strand, and after that, the capsular axis is done. Other than the opening part of the entry capsule, so this can be like the normal cataract. My lens will go into the back with the intact rhexis, and then we can do the primary posterior capsulotomy. You can see that the rhexis is intact. There are different challenges when the patient present late. What happens in Indian scenario, we can see that is a very old fusion of anterior and posterior capsule. These are tougher adhesions, they are difficult to remove. This doesn't come up with a vitrectomy probe, so we need to remove it with the scissor. Then inserting the lens will regain the good visual vision. This is another case where the anterior capsule is very tough. Patient has presented to us after 6 years of injury. Then we did the primary posterior capsulotomy. This is another case. We have published an article in Indian Journal that even with the older children or even in adult traumatic cataracts, we prefer to do the primary posterior capsulotomy and vitrectomy to improve the outcome for long term. Now there are other cases where the surgeries have been done, but you can see the type of secondary, despite of having primary posterior capsulotomy, secondary cataracts are developed. We need to intervene in these cases and remove the top membrane to provide the optical window, either for vision or for management of posterior segment. Another condition which we come across, traumatic vitreous hemorrhage, that was already dealt, but we can look at the picture. Here is the interesting case, as we could see the foreign body in CT scan, which was moving with the eye. So we understood that this is in the eye wall, but following removal of this, we could see that there is an opening in the posterior scleral wall. And the foreign body just passed into the either near the posterior part of the sclera or in the orbit. You can see there is opening in the sclera, but foreign body gone into the orbit. This is a traumatic retinal detachment. I think Prasanth is going to talk about this. But these are very different and complex type of retinal detachment, or having a very severe PVR with different thickness of the retina and difficult to deal with. This is a traumatic giant retinal tear. And these are the severe PVR. One another part is a traumatic endophthalmitis, which is having very poor prognosis. By it is actually very, because the organisms which are getting in are unknown organism and not normally present from the clinical setting. So this is the girl which was presenting to a 7-year-old girl with the injury. She presented after 24 hours. And that was the first picture. Following intravitreal injection, there is a second picture, and girl was no PL, no perception of light. And we did the lensectomy, vitrectomy, we did the full vitrectomy. We could clear out the whole vitreous. And then this was the situation. We left the child for 1 month, and then we did the scleral fixated lens with our special designed scleral tuck lens. That lens is done without any suture or without any glue. It is a self-sustained lens that we are going to talk about this. This is our designed and patented lens, which is available in India now. Very simple, small learning curve, anybody can do that. From no PL, this girl reached to 612 with correction. There is another wooden stick foreign body. When we saw this child. Child presented 7 days after injury, and this big foreign body was there, 24 millimeter long, which was present into the eye for 2 weeks. They were old exudates and very tough. We could do the core vitrectomy, could not perform the peripheral vitrectomy, and we pushed the foreign body from inside to out. It was a 24 millimeter long, and then we completed the vitrectomy, did laser, silicone oil. Patient removed only finger counting vision. Traumatic optic neuropathy, I think Madam Sujithra is covering. So we have some unusual foreign bodies, like these are some insect which was found in subconjunctival space, which caused esotropia to the child. On removal, maybe some toxic effect, the child regained the vision. These are interlenticular and the other type of foreign body. This is a traumatic telecanthus, well covered by Dr. Grover sir. And this is some difficult post-traumatic kinetic horn, which was also cleared following treatment. This is a chemical burns with the limbal cell transplant, giving you this result. And this is a symplepharon following chemical burns. Following management, following surgical procedure, the child has recovered the normal vision. There is electric burn in the child. Important is when we are talking about the child. So general anesthesia is very vital part. So we have developed a technique, optimum utilization of regional anesthesia with general anesthesia, and developed the special cocktail which can cause early recovery without much of a post-operative post-anesthesia complication. In this study, we published that 51 children, not a single children had any vomiting and immediate recovery following surgery. The moment we finish the surgery, we could transfer the patient to recovery area. So post-traumatic ptosis, then another adnexal area, but just I'll touch through this. So causes of post-traumatic ptosis before primary repair are maybe edema or injury to levator muscle or third nerve palsy. These are the causes for ptosis immediate after primary repair. Or other causes following repair are functional, mechanical, neurological, or pseudoptosis. This is the result after LPS surgery. This is a cicatricial ptosis. This is the result following. I think operating surgeon is Dr. Shreya, and I am not doing these surgeries. But this is just for, since they are in pediatric cases, I am displaying this. The Fasanella servet result. Lacrimal injuries. When we talk about lacrimal injuries, it can be a direct or it can be indirect. The most common injury in children is the blouse hook injury for the lacrimal patient, which will tear the canaliculi. The damage to lacrimal drainage system can cause the telecanthus, globe displacement, epiphora, and obstructive. If not, we have to face many consequences. More important is location of cut and confirmation of cut end, and suture it with different stents. I think she has used the various stents like Teflon, Prolin, or some indigenous stent which has been invented by her, and that has been published in the German Medical Sciences. Post-traumatic DCR are important. That post-traumatic DCR, because of following injury, there can be bone regeneration and some difficulty in opening the bone area. If we consider the orbital trauma which has been covered by Professor Grover. So these are the floor fracture or white eye trapdoor fracture. Challenging adnexal trauma also is to be taken care. This is the orbital foreign body. We have seen that 12 centimeter long foreign body removed from this child. So which has just gone into the frontal lobe, which was removed in association with neurosurgeons. There are animal infected injuries. These are the injuries which are repaired. This is the canalicular tear with LPS rupture. And this child was corrected and this much functionality has come. This is the end result. There is no leg of ophthalmos and everything is fine. So post-trauma strabismus, either because of supranuclear structure, oculomotor nuclei or nerves, extraocular muscle or combination. And this is the algorithm by Dr. Shreya, maybe early or late. If it is immediate, it may be direct or indirect, direct injury to muscle, pressure effect, or neurological damages in the orbital area. Or if it is indirect, maybe because of head injury, concussion. If it is late, it can be either local with the deprivational amblyopia or conjunctival adhesions, or if it is late, then it can be keratico-cavernous fistula or head injury. So these are the strabismus following orbital trauma. Here, the untreated patient where the fibrous muscle is entrapped is the entrapment of medial rectus. And this is a direct injury to the inferior rectus, which was treated along with lead, lacrimal, and this was published in German Journal Medical Science. And this is very good case. We can see the pulsation. It was a CCF, keratico-cavernous fistula, which was ligated. Following that, the person has a strabismus, and following strabismus surgery, he has become normal. Another area is a traumatic ectopia lentis, which is very common in children. We studied that if we manage well, the post-traumatic and ectopia lentis and normal ectopia lentis both can have a similar outcome. For all traumatic aphakia, there are various methods for rehabilitation. As we all know that glasses, contact lenses, entry-chamber lenses, iris glow, either anterior or posterior lenses. And I think this is an open globe injury. Then we perform the lensectomy and try to put the regular PMMA lenses, which has got more capacity to sustain in the, but after 2 weeks, the lens was dropped. We removed the lens and inserted the scleral tuck lens. So this lens works in all difficult situations as a scleral fixated lens. So this is the lens what we invented and designed and put into the market. There are two flippers tags which can be brought out 1.5 millimeter from limbus. This lens, either it can be done as a foldable lens or it can go through the pre-existing wound. We can use a trocar or anti-chamber maintainer. So there is no problem for the entry segment surgeon. With simple, some small vitrectomy, they can do this lens. We have published an article and another article for comparative study of scleral tech lens with other methods of scleral fixated lens, which is there in the Indian journal, which is in the press. Maybe in next issue it will be there. So we have done a study for visual outcome in our center. So we had 5,700 pediatric we had a 1237 pediatric cases in which were we analyzed. So the mean age was 9.7 for these children. Poor socio-economical condition is common in children, and we have seen the impact of visual outcome before and after treatment. So treatment definitely improves the visual acuity, and these are the pre-post visual acuity which has made the significant difference. Now coming to the type of injury, we have analyzed this, and in children, closed globe injury has got better outcome than the open globe injury, while it is exactly otherwise in the adults. And that were two articles for adult and for children are being published in either Graphes or in a European journal. And we also compared the visual outcome following traumatic cataract of congenital etiology and traumatic etiology, which also has been published in the European journal. And according to that study, the visual outcome is better in traumatic cataract. The objects of injury in rural India, because of that catchment area, wooden stick was most common injury, and stone. When we think about it, is a traditional knowledge that when there is a vegetative injury, we found that the infections are less common in vegetative injury. This also has been published in various journals, and we tried to find out some material on the bubble thorn, which is more common cause for injury. That is, the scientific name is Alosia nilotica, which has got some protective mechanism for infection, antifungal and antibacterial activity that permits, that does not allow infection to happen in these cases with the wooden stick injury. And if we look at the tissue, most common tissue to be involved was the cornea. Second is the lens. And if we study the number of tissues involved in the ocular trauma, the more number of tissues involved, visual outcome is poor. Obviously, because of child, the visual outcome is the causes of injury, activity during injury is the playing. And the factors which are more important for non-improvement of vision is corneal opacity, recurrent inflammation, lens malposition, secondary glaucoma, extensive posterior segment, and other causes are amblyopia, astigmatism, and after cataract. For amblyopia, there is an important tool. What we are using now is perceptual learning with hand-eye coordination, which has given the dramatic result and improvement in the amblyopia management. It is very important that we understand about the predictive models. The most common predictive model, which is published by Professor Kuhn et al., but that is very old, and that is it for general. When we consider the pediatric patients, we have two another prognostic models. One is a pediatric ocular trauma score, and another is a toddler ocular trauma score. So if we consider these the comparative methods, if we understand how to calculate this, so presenting visual acuity is the most important factor by which the score is calculated in OTS and POTS, while In toddlers ocular trauma, clinical findings and zones are more important factors which we need to consider. And for OTS and PATS, 0 to 5, more severe to less severe, while in toddlers ocular trauma score, 5 to 0, more severe to less severe. This is how do we calculate. The OTS has got row scores and subsidiary calculators. These are the conditions which we need to deduct. But if we consider the child, we have added two another variables. One is the row point according to year and row point according to the wound location. The both deductions have been made and POTS has been calculated. While for toddlers ocular trauma score, we considered the wound of size, IFEMA, traumatic cataract, retinal detachment, choroidal rupture, zone 2 and zone 3. So this is 0 to 9. If we can have a more score, more severe the injury and poorer the prognosis. This ocular trauma score has been studied in adult as well as children, which again has been published in ophthalmology as well as in JCRS. And there is another score, I think SR et al. And the Lily Zhu has published this, but they published only in the penetrating ocular trauma. And we published the pediatric ocular trauma score for all injuries in Graphe Archives. This is the comparative study for all three scores. In lower scores, the toddler and pediatric ocular trauma score has got superior prognostic values, and in general, ocular trauma score has got superior prognostic values. So our target is to save life, save vision, save cosmetic. Thank you. Thank you very much. And we invite you all to be there in TraumaCon during 14th, 15th May, Gwalior. This is a physical conference.
Thank you so much, sir, for that very exhaustive and broad presentation. And it was very visually rich and appealing. All the videos and the photographs were so beautiful. We all enjoyed and gained so much talk. Thank you so much, sir. So I think we will move on to our next speaker, Dr. Biju John. He will be talking to us on intraocular foreign body. I'm sure Grover sir has made his task much easier. Anyway, he'll be talking to us on the Kerala-specific situations and challenges that management of intraocular foreign bodies we all face with. Over to you, Dr. Biju.
Yeah, okay. Hope I'm audible. Yeah. Thank you, Litika. Thank you, TACO, Ksos, and the organizers of the CME for giving me this opportunity. I think my topic given to me is intraocular foreign body management, but I think it has already been extensively covered by Dr. Natarajan, and I don't think anybody can match that speak and the type of video that he has shown. I think Dr. Mehul Shah has also talked on that. So just probably TACO feels that the IOB is so important. So that is why a repetition, they don't mind a repetition. So I will probably talk about it in a little more limited setup because I'm working in a government hospital. So there will be some limitations. And we'll be showing you a few scenarios which has baffled me and which could baffle you also. So I'll begin with one slide which tells you the history and the geography in one slide. So you got a source of the foreign body like this, and that is the foreign body. The patient says there is something hitting his eye. You can see the path of the foreign body. So when you look at this patient with the history, these are the signs that you should be probably looking for. A corneal laceration, which would sometimes be very difficult, but always look for an iris hole. Then it can rupture the lens, so it can produce a cataract, can also produce a subluxation. It goes and hit the retina, producing a vitreous hemorrhage, so which if not much, you will be able to see the foreign body. But don't expect the foreign body to be in the site where it has hit the retina first, because it can ricochet and will be in another location. So these are the things in a typical case. So this is a typical case where you got a typical history of a workshop worker, a young male, hammer on metal, that is the history. And you see this. So just like that previous picture, you see the ruptured lens. And of course, unless otherwise proved, there is a foreign body inside. So what is your imaging of choice? What is your next investigation? So it would always be a CT scan, but I would like to emphasize regarding the cut size here. You need to go for a small thin slices, 2 to 3 millimeter, in order to pick up this foreign body. So it has picked up the foreign body. It has localized it in retina. Probably it is incarcerated in retina. And so in time to think for the management. But do we still need a B scan in this picture? The answer is yes, because even if you have localized the foreign body, the B scan would be helping you when you plan the management. For example, it will be showing you whether there's a PVD, whether there's an associated retinal detachment, is there a coronal hemorrhage. So all these things can actually influence the planning of your surgery, how exactly you are going to execute it. So a B scan is needed. There are a few other uses also, which I will tell you in the subsequent slides. So the management, you have to have one question. When you have something like this, whether you do the cataract surgery in the first sitting, followed by a vitrectomy in the second sitting, or you do everything together. It depends upon your setup. So I had an opportunity, I was working where I could do everything in one sitting. So this is a 23 gauge, the Frockards being introduced before tackling the anterior segment problem. So I could do a Rexus here, which was, and using the phaco probe, I removed the lens. It was used up to the point where the vitreous was encountered. After that, the phaco probe was removed and everything else was then continued on with the vitrectomy probe, which is a wonderful instrument for tackling the vitreous as well as the cortex. And these steps I'm not, Natarajan sir has already explained beautifully. That is the cord vitrectomy and removal of the vitreous and everything. So the foreign body can be seen impact in the retina. So I always prefer to do the entolaser around that site of the foreign body before tackling the foreign body itself, because I'm always afraid of a hemorrhage or later, even though people can do it in the other way also. So that is the foreign body which is being dislodged from the fibrotic capsule. Sometimes you may have to incise it with a small blade or some things if it is a little delayed. So the foreign body is now grasped with the end grasping forces. It is brought anteriorly and it can be taken out through the enlarged spot here. So this spot has been removed and it has been enlarged so that the foreign body can be taken out. Sometimes the orientation has to be changed a little. Now, so that is sutured, and now as you can see, the rest of the vitreous and everything is removed. And because there is an intact capsular axis there, I could just place a routine 6 mm PMMA lens in the sulcus. So the outcome was very good here. You can see this is a 3-month postoperative picture, and the patient had very good vision of 6/9. So this is the area of the foreign body impaction, that is the laser burns, but this area is absolutely clear, explaining the good vision. Now, another situation, when you have a wrong history but the right geography. Yeah, you can have a situation like this. I mean, this was a 45-year-old man referred for cataract surgery. So slit lamp revealed a surprise. So there was this sort of an iris fault. But in spite of repeated asking, so whenever you see an iris fault, no previous history of surgery, when it is backed with a suitable history suggestive of foreign body injury or a trauma, unless otherwise proved, it has to be taken as an evidence of intraocular foreign body. But in spite of repeated digging and asking the patient, he could not tell me any corroborating history. So he doesn't remember anything like that hitting his eye at all. Now the eye was pupil was dilated, which is anyway required for the cataract evaluation, and we could see the intraocular foreign body, which is an intralendicular foreign body. So this is the location. Now, once this is localized, it is easy. The intralendicular foreign body is probably the easiest location as far as management is concerned, because it can be done along with the routine cataract surgery. So that was done. So just emphasizing this, because you can have situation like this also where you don't get the history properly. Now, do you need further imaging? Because the foreign body is obvious. So we did the imaging, so the CT scan, this is needed because who knows that there is another foreign body there. So it's always better to do an imaging, especially with this sort of a history. Okay, so you can have perfect history, but the imperfect geography also. A 30-year-old male mechanic, a beautiful history of being hit in the eye by a metal piece while walking in the garage. Okay, such a history, you immediately look for foreign body. No, you need to find out the signs of the foreign body because you guess that there is a foreign body there. And this was what we found out. So you can see there was no evidence. The cornea was clear. The lens was crystal clear. There was no hole in the iris. In spite of looking everywhere, I mean, there was no evidence of foreign body which could be found. But the entire ophthalmoscopy, there was vitreous hemorrhage. We did the imaging, which showed the foreign body. So again, to emphasize a situation where you may not know that history is important, but geography may be a little misleading here. So again, the importance of the proper indirect and all these things. So this is the patient. You can see the vitreous hemorrhage there. So having removed all the vitreous hemorrhage, you can see this foreign body. So it must have gone through the ciliary body area or sometime without actually injuring the cornea or the iris. So the large electromagnet was actually used after vitrectomy. Once the vitrectomy is completed and you're sure there is no vitreous there, then you can use a magnet like this. This is another such case. This is a graphite tip of a pencil tip, which was which got lodged in the anterior chamber, angled in a child. This was a sort of an injury which happened in the school. Now, in these cases also, it might be great difficult to get a history because you know how the children hide their history. He was so loyal to his friend that he never wanted to admit that there was a fight between his friend with a pencil. And only when the patient presented with some amount of uveitis and a cataract, which led us to investigate further, including a curioscopy, we found out this graphite tip was due to a pencil and which we could take out. So these are the situations where you may not get a proper history. Now, Natarajan sir has also emphasized the fact that the IOFB's common age group is young males. But there are two interesting scenarios where I have seen females are involved. Now, this is one situation, burning of household waste. Why it is like that? Probably what happens here is that because there will be some bottles inside and these bottles explode. Maybe men are more aware of the anatomy of the bottles and how they explode. They are so careful that the cases that I got were mostly females. So this was such a case. So this was the situation after repair, after the primary repair. You can see this is the injured, this is the sutured wound, which is the entry wound. This is a large wound and the lens has been removed. The CT scan shows the foreign body and localization is important. We localized the site of the intraocular foreign body as here because there was fundus view, but the intraocular foreign body, even though it is so large here, was not visible in the indirect ophthalmoscopy. And we localized the probable site of the triangular foreign body. This, how we did was because of CT scan, they did a beautiful 3D reconstruction. So this was the shape. And after we got this, we repeated the B scan and sort of localized exactly with the nasal transfers. So the B scan probe only when directed so peripherally, which you usually don't do in your screening. So verified that the position was here. And once that was done, then the management was easy. But we used the iris hooks in order to retract the iris so that the edge of the foreign body is now visible. And use this, I mean, this is the only other forceps that we are having other than the engrasping forceps. This is a three-pronged forceps, works in most of these large foreign bodies. So that is the glass piece. So I was holding that, and this was one case which really had me worried because I was always worried about the glass piece, slipping, and couldn't even think what would happen if it did. But anyway, fortunately, that didn't happen, and I could retrieve the glass piece, which was quite a large piece. Even such a piece, which is about 14 millimeter in its length, would stay hidden from your sight. Even from the indirect ophthalmoscope, shows the type of situation or type of location that the foreign body can sometimes be. And there was a retinal tear also in that case, which was nasal after vitrectomy. And this was the picture after the case, and this is an iris core lens. You can see that this was usual position iris core lens was not possible here. So this is being implanted from the temporal side in a vertical location. That is how this versatile the iris core lens is that even if the horizontal implantation is not possible, you can always go for a vertical implantation, which was done in this case. And this is the case after 6 months. She attained a best corrected visual acuity of 6/12, and the iris flow is sitting just great here. Now, another case, the 28-year-old male. His history was there was an injury with the iron nail at left eye at work. Now, he brought the iron nail also. So he was pretty confident that the iron nail has actually came out. So we were also a little, sort of comfortable. The iron nail, whatever has come out, and it was a full nail. So probably there is nothing inside. So there's a 6 millimeter long full thickness pleural wound, 2 millimeter from the nasal limbus. So it was required. That was total hyphema. CT scan, of course, is mandatory, even if that whatever the history in any open globe injury, CT scan is mandatory. So we did the CT scan. There was no evidence of intraocular foreign body. P scan showed vitreous hemorrhage. There was no RB or UFP as per the records. And at the time of discharge, after 1 week, the hyphema had resolved. The vitreous hemorrhage was just beginning to resolve. This was brought to me for a VR opinion when the patient came for the next review after 1 week. And this was what we found. So we could see these small, snowball-like opacities in the inferior vitreous. So this was evidence of some sort of inflammation going on. And you can see that the vitreous hemorrhage is still sort of absorbing. So it led us to think whether we had missed something, and on closer examination, the periphery, we saw this thing. This was a linear sort of foreign body with a lot of X-ray around this. So probably this is an organic foreign body which has evoked an inflammation diagnosis, which must have been missed initially. So we thought it is a wood piece, and that was why it didn't show up on the CT scan. Now we repeated the B scan and of course could locate it. But why was it sort of missed in the initial B scan? So this brings to your usual picture of a screening B scan when you concentrate more on the posterior report, and usually doesn't, sort of shift this probe to a position where it can image the periphery. If that is done, sometimes you might miss these sort of foreign bodies in the periphery. CT scan will anyway miss such foreign bodies, wood foreign bodies, now organic matter, etc. So we probably thought this is a wooden splinter. So this is again, in such a situation when the history is suggestive, history is very suggestive, and then we are not seeing anything on the CT scan. So you should consider CT scan with the soft tissue window settings or for an MRI. So once you are sure there is no metallic foreign body inside, but in this case, you may not, the history, you cannot say it is so suggestive because the patient had actually come with the nail, he has brought that. So there was no reason to suspect that an organic foreign body was inside. So this was the case. So this is the foreign body during the vitrectomy. It was a long linear piece. There was a vitrectomy done all around it. Now another bad thing happened during the surgery was that the patient, who was sleeping during the surgery, suddenly chose to wake up at an unfortunate moment, that suddenly everything went black. I could just sort of take out my forces or so I thought, but I found that I had actually nicked the retina. But fortunately for me, it was the nasal part. And so I again concentrated on the foreign body. So that was the foreign body which is grasped with the forceps and that is being taken out. So that is the foreign body which is being brought out. You can see that it is nothing but a pair of the patient's lashes. How do you guess these sort of things in your history? So this is another, so that is the endolaser being done at the area of that pectoral injury. So again, to emphasize or bring into another factor that hair or the lashes can go inside with any sort of open globe injury. So even if you tell that the foreign body has come out entirely, things like this can go inside. This again brings us the value of a thorough B-scan evaluation, especially the periphery in such cases. So patient had a good outcome because this area of injury was very far outside the macula. So he had 6/6 vision. Now this is just to a case which was referred from the medical college for ER intervention because of the intraocular foreign body. This is just to show you how a perfect referral should be. You can see that the lens has been taken out. So a beautiful vitrectomy has been done. So the primary repair is done. No IOL has been placed. It is actually better to don't place the intraocular lens during the primary repair because the VR surgeon might have to use that anterior route also for taking out the intraocular foreign body if the size is a little too large for it to be taken out through the pars para route. So the IOFP was localized here, and another important thing which was good here was that intravitreal antibiotic was also given. So that is also another very important thing that do during the referral. Now, stone foreign bodies are really difficult, maybe not for people, Natarajan sir and all, but me with the limited type of instruments, I had a terrible time with this intraocular foreign body. So this was a large, as you can see, the large entry wound, and the suture tunnel is also seen here. The lens has been taken out, and now it is time for the VR intervention to take out the stone foreign body. So these were the other forces which I had. Probably it was not a very good instrument to pick that up, but didn't have anything else. And the stone piece broke. Now this is the problem with the stone foreign body. It is sometimes so brittle, and so this was a sort of a snare which I fashioned from a cannula, which helped me in that situation. And using that snare, I could take out the intraocular foreign body. Now, then that area of the damaged retina was repaired, and IOL was later implanted. And 6 months later, okay, the patient had a good outcome. So this patient, I even used the silicone oil also because I didn't want to risk the detachment there. So this is just to show the two ends of a spectrum, showing the challenges in intraocular foreign. This was a case with vision only PL, a large glass foreign body, totally damaged retina. This is a case of a foreign body which is impacted, outside the macula with a 6x6 vision. Now, this would be easy probably than this case, but I would probably be more uncomfortable with operating on this case. So these are the two ends. So as sir was emphasizing, the fight with intraocular foreign body just continues. It is fascinating, exciting. Every day you tend to encounter new problems. So some of these cases are very difficult, but again, as sir was telling, we should not actually give up and try our best to give the patient an optimal outcome. Thank you.
Thank you, Dr. Biju. It was a totally engrossing presentation, and we were really watching ophthalmic trauma theater. Thank you so much. And your animation was really stunning, and the variety of cases shown is very much appreciated. Really, really great talk. Thank you so much.
Thank you.
So now we can move on to the next topic. Let me call upon Dr. Sujithra to speak on traumatic optic neuropathy.
Okay, thank you. So Biju, it was wonderful.
Thank you, sir.
I thoroughly enjoyed.
Thank you so much, sir.
I think in case whatever the animation video, in case you can spare, I'll text my email ID. You can send me. Really, the wonderful. I learned a lot.
Yeah, okay, sir.
And
Thank you so much.
I just read that you're working in medical college. It's, I think, hats off to your medical college and you.
Thank you so
animation, much. Everyone wants it, sir. Do share it with all the panelists today.
Yeah.
It was wonderful.
Prasanth, this is only for people who are logged in from 8:15.
No. But the postgraduates, definitely all institutes, it's worth explaining. Very easy to explain. It makes it self-explanatory rather.
Thank you, sir.
Dr. Sujithra, would you please?
Audible?
Yeah.
So that was an excellent talk by Dr. Biju and our previous speaker, Dr. Mehul. Now, my topic is traumatic optic neuropathy. First of all, I thank Dr. Sudha for including me in this session and thank Dr. Latika for the warm introduction. The traumatic optic neuropathy. So we all come across this situation. I will start with 3 case scenario, then we'll go to that proper discussion. So case number 1 is a 28-year-old male presented with loss of vision in right eye following road traffic accident. Vision in right eye was no perception of light, and there was proptosis and restriction of all ocular movements. There was eyelid ecchymosis and chemosis. And left eye was normal. CT scan showed fracture of all walls of orbit, and there was hematoma in the orbit and also in the sinus. So we gave intravenous methylprednisolone and for 3 days, then switched over to oral steroids, and cantholysis and evacuation of orbital blood was done, but vision did not improve. The 57-year-old male, he presented with a decrease in vision in right eye following RTA. He reported 4 days after the trauma. Vision in right eye was 6/60, improving with pinhole to 6/80, and left eye was 6/12, with pinhole improving to 6/6. And there was RAPD in right eye, color vision was defective, suggestive of optic neuropathy. Left eye was normal, and fundus examination also was normal. CT scan, which he had, reported as normal, and there was no evidence of any intracranial bleeding. MDCT was done, which showed fracture of lateral wall of Sinha sinus with fracture and hematoma. Maybe a doubtful indentation into the optic nerve. Intravenous methylprednisolone 1 gram per day was given for 5 days, followed by tapering dose of oral steroid. And his visual acuity in right eye improved to 6/12 with pinhole 6/9, and color vision also improved a bit, and we can see the improvement in his field effect. This was 10-2 field effect, this was at presentation. This is 1 month after the trauma. Case number 3, is a 27-year-old lady, had history of road traffic accident, presented with loss of vision in right eye, and vision was perception of light, and PR, projection of rays, was accurate. There was RAPD, fundus was normal, and the CT scan showed fracture orbital wall and hemosinus, and there is compression over optic nerve. She was given intravenous methylprednisolone, endoscopic orbital decompression, and optic canal decompression was done, and her central vision improved to 6/6, and there is improvement in visual field also. So when we analyzed 34 patients of traumatic optic neuropathy, the common age group affected are young patients at about 34, and males are more commonly affected than females, as mentioned by the previous speaker. And road traffic accident is the common cause for traumatic optic neuropathy, and indirect traumatic optic neuropathy is more common than direct optic nerve injury. And most of these cases are associated with orbital fracture, and lateral wall involvement is more common than the other ones. Of these patients, 5 patients underwent conservative management, and 24 patients received steroids, and surgical decompression was done for 5 patients. And we found that eyes with poor presenting visual acuity had poor final visual outcome. And lateral wall fracture was the most common fracture associated with indirect traumatic optic neuropathy, and it is associated with poor visual prognosis. So traumatic optic neuropathy can be direct or indirect. Indirect traumatic optic neuropathy is the most common form of traumatic optic neuropathy. The mechanism, the blunt trauma, the forces, there is shearing force in the optic canal, causing damage to the nuchal vessels, leading to optic neuropathy. And force of impact from the forehead can be transmitted through the lateral wall to the optic canal as a shock wave causing optic nerve damage. These are the two proposed mechanism of optic nerve damage. Direct optic nerve damage can happen due to any fragment compressing the nerve, or can have orbital compartment syndrome because of active hemorrhage in the closed compartment, that is orbit. This is an ophthalmic emergency that requires immediate intervention, that cambolysis, and we have to release the orbital pressure. And direct optic nerve injury can happen due to penetrating injury. There can be transection of nerve fibers or compression from hemorrhage or edema, or there can be impingement on the nerve by a foreign body. Optic nerve head avulsion can happen due to rotational injury. Optic nerve head avulsion, it presents as there is profound vision loss, and there is prepapillary hemorrhage, and it obscures the view of optic nerve head. When there is a posterior avulsion of optic nerve, we have to investigate and rule out significant skull-based injury or intracranial injuries. Rare cause of direct optic nerve injury is optic nerve hematoma. It presents with signs of progressive visual loss, unlike other trauma where it has a sudden vision loss. But here, this hematoma causes slowly progressive vision loss. Initially, at the time of trauma, patient may be having vision and which deteriorates over a period. So fundus examination may reveal venous or arterial occlusion, and CT imaging may show expansion of the optic nerve. Coming to clinical presentation, patient can present with vision loss, either unilateral or bilateral, the total vision loss or partial vision loss. And visual field analysis should be done whenever it is possible. Most of the time in acute trauma, we won't be able to do the visual field analysis. And the shearing force into the posterior indirect optic neuropathy, it causes immediate vision loss. Compressive optic neuropathy from hemorrhage, it develops slowly. And avulsion injury causes sudden vision loss. Coming to signs, there is a decrease in visual acuity, and RA pupillary assessment is the most important examination we have to do in the setting of acute trauma. That can be orbital hemorrhage, that can present as compartmental syndrome, and ophthalmoscopic examination. Most of the time, dilated fundus examination won't be allowed because of head injury. So whenever possible, we have to do dilated examination. Otherwise, through undilated pupil, we have to examine. So there can be signs of vascular compromise or Berlin's edema we can see, or vitreous hemorrhage, prepapillary vitreous hemorrhage with profound visual loss suggests optic nerve head avulsion. Coming to evaluation, following head trauma, CT scan is the best investigation we have done. So we have to image head and should have head orbit and adequate view of optic canal. So we have to do 1 mm section. Routine CT is done at the interval of about 3 to 5 mm section. So at that time, we might miss optic canal fracture. If metallic foreign body is not suspected, then we can do MRI to look for hematomas. And as I said, when there is progressive vision loss, then we have to do MRI to find out if there is any hematoma. Coming to treatment, for optic nerve avulsion, there is no effective treatment, but we have to investigate and evaluate for severe brain injury or skull-based injury. And coming to indirect traumatic optic neuropathy, again, no clear benefit to megadose of intravenous corticosteroids have been proven. There is a prospective study of corticosteroid use in traumatic brain injury, which shows increased long-term morbidity and mortality in patients with brain injury. Corticosteroids should not be given for patients with severe brain injury. Then there is also animal study which shows that corticosteroid can have axonal injury than no treatment. Then there's a National Acute Spinal Cord Injury Study. It used megadose corticosteroid, and it shows that it may be beneficial if given within initial 8 hours of trauma. So this finding has been extrapolated for the treatment of acute traumatic optic neuropathy. The rationale being the corticosteroid is neuroprotective effect as a result of its antioxidative effect resulting in reduction in inflammation following trauma. The International Optic Nerve Trauma Study, it shows that no significant difference in visual outcome among patients treated with corticosteroid, surgical decompression of optic nerve, and the untreated patient. And they also found no association of timing of corticosteroid treatment with the visual impairment. There is another study which shows that either of the treatment was better than no treatment. Traumatic optic neuropathy treatment trial against concludes that there was no improvement in visual acuity in patients who had either intravenous erythropoietin, steroid, or no treatment. There is no significant difference among these groups. So there are few studies which supports use of steroids. And coming to surgical optic canal decompression, again there are few studies which supports the surgical decompression of optic canal even with normal CT. But again, this is controversial. There can be the surgery can have additional injury to the optic nerve. So again, we can't take this as definite treatment. And coming to orbital compartment syndrome, here we have to treat this as an emergency and we have to release or decrease the orbital pressure by doing good tranquilizers. And we can give intravenous corticosteroid, which reduces the edema, and it should be given in patients without traumatic brain injury. So to conclude, regarding management of traumatic optic neuropathy, there is no standard guidelines. The corticosteroids are avoided in brain injury. Orbital compartment syndrome, we have to intervene immediately. And surgical optic nerve decompression, again, it is controversial. Thank you. Thank you for the opportunity.
Thank you, Dr. Sujithra, for the comprehensive coverage of a confusing topic. Actually, I think the most important takeaway from the talk is that we should not have the idea that we can just start off steroids for any patient with a suspected traumatic optic neuropathy. We ophthalmologists generally don't tend to look at the GCS scores of any patient. So it would be a good idea to look at the GCS scores and see whether it's less than 3, or even to, when you write steroids, to add that if the neurologist thinks that it will not produce a deterioration of the head injury, that word also can be added. So that is a very, very relevant point that Dr. Sujithra has highlighted. So now I think we can, because the scientific talks are over, we are now open to discussion. So Dr. Jyoti,
Yes,
how
you
much
can
time do I have?
Yes, you can have discussions actually. Yeah,
Thank you so much.
you can.
So let's start with the first topic, that is pediatric ocular trauma. As we know, trauma itself is a very challenging situation. We have to expect the unexpected. In a child, it is multiplied. Challenges are multiplied. So Mehul sir had very nicely covered all the points. Still, sir, could you please highlight the most, what would be the top 3 tips that you would like to give us in management of pediatric trauma, especially the initial part of, assessing the injury and all that, which is very challenging.
So I think as we all discussed during these sessions, our first primary repair will be very, very important, and quality of primary repair will be reflected. Then immediately in children, we have to take the second sittings, and as Dr. Natarajan said that it should not be delayed. It should be as early as possible within 100 hours. And once we clear out the optics, then the another component which is not there in adult trauma is the amblyopia we can take care. So despite of doing our excellent job, there will be some corneal scar or some problems will be there. If there is problem, we have to tackle with the rehabilitation using the scleral fixated lenses, giving proper refraction. So if child has got irregular astigmatism, corneal scars, need to take care of that amblyopia part first. Otherwise, all efforts will be in waste.
Thank you, sir. One more thing is, even in the initial assessment of a child coming with a suspected penetrating injury, we are sometimes, the post examination itself is supposed to aggravate the trauma. So, and EUA may not be always possible also. That is a practical problem that we ophthalmologists usually face. So, are there any tips to go easy on the examination, examination of the child?
If we understand that there is a serious trauma during primary assessment, then we have to take the patient under anesthesia if there is no polytrauma situation. Without that, it is extremely difficult. And as I told in the prognostic models, that in children, rather than initial visual acuity, our clinical findings should be important indicators to prognosticate the patient.
Okay, thank you. So another thing is, during the IOL implantation, if the patient already has a corneal scar or corneal injury, the biometry part wouldn't it be a challenge to do a proper biometry in that time? How do you do a biometry? What biometry do you prefer?
I think you need to take the reference of other eye, corneal curvature, and axial length of the same eye, which will be able to calculate the near accurate power. Exact accuracy may not be possible because it will be irregular astigmatism in the case. And in our country, we don't find corneas for each and every corneal scar patient.
Now, moving on to our next topic, that is intraocular foreign bodies. This question to Dr. Biju. You had shown a variety of cases, many of them showing cases where the CT scan missed certain foreign bodies, the ultrasound picked them up, and sometimes the MRI was used. So how do you really customize your investigative protocol? How do you go about deciding which patient needs scan, which would be your first choice of investigation in a case of suspected intraocular foreign body?
The first choice of investigation is obviously a CT scan. CT scan is important, but the slice thickness is something which often the juniors or the postgraduates sometimes forget to write. I think that is important. And even after the CT scan, whether the CT scan returns anything or not, I think the B scan is something which is very important in this thing, because it will pick up some of those foreign bodies which, for example, that organic foreign body or a hair can be picked up by the B scan. But this was something which I also learned the hard way, because I was also not doing very meticulous B scan initially, especially directing the B scan probe to the peripheral side as a part of your screening. That is also done. I think the CT scan and the B scan as a combination will pick up most of the foreign bodies. And in some of those indicated cases, when the history is so suggestive and you don't find anything, then probably an MRI. But MRI is not usually done in my as a routine.
So that CT scan with soft tissue window would be a good option. I mean, good alternative to an MRI.
Yeah, it would be, but generally, as a screening, you will be usually doing a routine CT scan, because that will probably, depending upon the intensity, it will probably actually help you to differentiate whether the foreign body is a metallic foreign body, a foreign body. So for that, I think the settings has to be like that. So if you go for soft settings, only when these things doesn't usually turn up in the screening. Most of the foreign bodies will be caught in your routine.
One more very practical situation that we are usually caught in, that is all setups don't have a VR surgeon. So what if there is a penetrating injury and intraocular foreign body in the vitreous? So would you suggest, what is the next step that you would suggest? Is it like repair and referral, or is it repair and an intravitreal injection of antibiotics referral, or is it referral stat? Which would you advise as a take home?
Yeah. I mean, again, a very, very important question. That is why I devoted one slide for that. So I'd always prefer a primary repair, because I think most of our centers have got good microscope, as Natarajan sir was emphasizing. So they can do a primary repair easily, but do an intravitreal injection. Because even if you calculate that the patient may reach the PR center in maybe 2 hours, 3 hours, I mean, there can be delay. Even at that site, it will be first seen by the casualty. Then need the call goes to VR surgeon. So it's always safe to give an intravitreal injection then refer.
Any other panelists would like to add on to that?
Dr. Biju's talk has really been comprehensive and fabulously illustrated. I think we all have learned a lot. I think that is what I would like to emphasize, that we follow what he has said.
And regarding traumatic optic neuropathy, one more thing is Dr. Sujitra's series of 5 patients who underwent surgical optic canal decompression. I mean, what is the average success rate among this?
One didn't improve. He remained an OPL. Other patients improved. Because all these direct, it was for direct optic neuropathy.
Is there any role for Wolfram protocol for surgical correction of neuropathy?
No, still it is not definitely.
Right.
We can't do case control study in this situation. We don't know if we observe the patient would have improved, or the surgical whether the improvement in vision is due to surgery or
Or up to what time duration we can try that surgical correction from the date of injury? Up to what duration it may be useful?
The same question applies to whether you would give a pulse steroid therapy if the patient presents 3 days later, 7 days later, 2 weeks later. I think both questions.
Yeah, the report, there is a report which says that there is improvement in visual acuity with steroid within 3 days, and even after later on also, if we start steroid, there is improvement. But we can't.
Practically, when would you not consider it? How long after the
optic atrophy sets in? Then
I think I beg to differ there. I think there is a guideline from the crash study which says that more than 8 hours, it is better to avoid steroids in a case of traumatic optic neuropathy, especially if associated with the TBI.
But still there is studies, and also in my patient which I showed, the second patient, he reported after 4 days there was hematoma. So he improved with steroid, but we don't know whether it is due
Even
to
if it is a case of now avulsion, then also it can respond.
No, definitely no there. There now in avulsion injury, then we have to concentrate on his life support, his brain injury and skull-based injury. Then
I think
another point.
Yeah, please go on. Please go on.
Now, distracted by
So,
okay. So the takeaway is that steroids in traumatic optic neuropathy is still in flux. So there are people.
Even if you don't give, it is not a mistake.
Yeah.
So what I would say is, in conclusion, that if there is a clear-cut compression, bony compression that can be shown, you should intervene, particularly if the patient has presented within a week, I would say. And if it is the ethmoids or those areas which are endoscopically accessible to an ENT surgeon, that is often the best approach.
Yes.
Sometimes orbital approach, transcaruncular is also a good approach. But for more posterior ones, sometimes the sphenoid is involved, then a neurosurgical approach may also be needed. But where there is a direct compression on nerve shown by the radiologist, I think intervention is called for. Although I would not say that majority also would improve, but yes, you are probably not justified in not intervening in those cases.
There is always the risk of surgical trauma to additional. That is there.
IV methylprednisolone I would give for any patient presenting within the first 2 weeks. Of course, the talk about giving the supra high doses, the spinal injury doses, is now no longer done because of the fact that even though there were some results which showed improvement, there was an increased mortality shown in those cases because of various factors associated with associated injuries or with use of steroids. So those are probably no longer, supra high doses of spinal injury are no longer taken into consideration. So there are no obvious clear-cut guidelines. The multi-centric study which was done could not recruit enough cases. I think they just had about 131 cases, and that too, there was not enough follow-up globally. So they could not come to a meaningful conclusion with regard to what is the best modality. But overall, I think IV steroids are still standard if patient is presenting within the first couple of weeks. The rest is only if you show a bony compression or a worsening after a certain visual acuity was recorded earlier, that you would think of a surgical decompression. Of course, for a compartment syndrome, there is no question. It should be an absolute emergency taken immediately to the casualty and immediate catholysis and opening up. And there's no question there.
Thank you so much, sir. So to put that in
the orbital compression syndrome, I think that the value of the cantholysis was very good, which is something which we always emphasize. I also seen a lot of patients improving. But only one question is that, some of this orbital hemorrhage. So when do you decide that a cantholysis is not enough and we should approach somebody like an ENT surgeon or neurosurgeon for an endoscopic decompression?
No, I think for any orbital hemorrhage, orbital compartment syndrome, an orbital surgeon is, oculoplastic surgeon is more than enough. A canthotomy, cantholysis, at worst, a little intervention with your scissors to go deeper into the orbit from that area, from the lateral canthus area, to make sure that a decompression has taken place is enough. You don't need any additional decompression in these cases once you have done that.
Thank you, sir. Thanks. So to put things in a perspective, in a nutshell, in traumatic optic neuropathy, if there is an orbital compression syndrome developing, there is no doubt that we have to intervene as an emergency with either cantholysis or at least a canthotomy. Second is, if there is a imaging evidence of a hematoma building up in the optic nerve sheath, then we have an optic nerve decompression may be indicated with guarded prognosis consent from the patient. If there is no TBI, that is no significant traumatic brain injury, then you can consider IV methylprednisolone, though not in the mega doses, anytime, maybe till 2 weeks. And if there is a traumatic brain injury with a low GCS score, it is better to withhold steroids or at least give it only in consultation with your neurologist. So I think that summarizes the traumatic optic neuropathy part of the session. Thank you all for your wonderful inputs. It was really great being part of this.
Thank you, Litika. Fourth session is on complicated scenarios in trauma. I invite Dr. Anup Cherayat, Medical Director, Eye Vision Eye Hospitals, Thrissur, to chair the session. Over to Dr. Anup.
Thank you, Dr. Jyoti. Very good afternoon to all of you. It was a really magnificent CME so far. Beautiful, wonderful talks by senior faculty, beautiful videos. So now we come to the last session. So the last session again is on very important topics. So we have very star speakers here in this session also. So we can expect a lot of good information here. So the first speaker, the first talk is on chemical injuries, which we all know is something very common and sight-threatening. So we have Professor Rajesh Sinha. We all know him very well. We see his face on all the communications of AIS and now FBS also. But anyway, formal introduction is in order. So Professor Rajesh Sinha is a professor in cornea, lens and refractive surgery services at RP Center, AIMS. He had done his MD from AIMS, and then he did his DPNB, FIA, CL, and FRC, and then did a fellowship from the University of Washington. He has more than 364 publications. That is a huge number. To his credit, he has authored 4 textbooks and 5 educational manuals. He has been a part of 3 multicentric FDA clinical trials. He has received various awards, notable which among them, there have been a lot of awards, but we are just summarizing it. Some notable of which are the Achievement Awards of the American Academy of Ophthalmology, the APAO, and the SARC Academy of Ophthalmology. He has been appointed the professor of the Asia Pacific Academy of Professors in Ophthalmology, and he is a recipient of many notable orations in the country. Currently, he is the treasurer of the AIS, the treasurer of the SARC Academy of Ophthalmology, the General Secretary of the Indian Society of Cornea and Keratorefractive Surgeries, treasurer of the EPIA, and also the General Secretary of the FBS, the Family Benefit Scheme. So, over to Dr. Rajesh Sinha for your talk on chemical injuries.
Thanks a lot, Dr. Anup, for the kind words. I would also like to thank KSOS and TACO for having me here, Dr. Grover, Dr. Mehul, Shah, and everyone. I'll be presenting on ocular chemical burn. And we all know that chemical burn is a medical emergency. And we have to tackle it in its acute stage first. That is the most important thing. Preventing the sequelae is the key. So that is very important. But if at all there is a chronic sequelae, we have to handle that as well. And as I said, a very bad condition, which definitely needs to be handled with great urgency. The common agents can be alkali, can be acid. And as we know that acid injury does appear to be devastating, but it is not that damaging as alkali, because what happens that with acid, there is collagen shrinkage, and because of that, it resists the passage of the chemical through the collagen. And in alkali, what happens, there is saponification of lipids in the cell membrane, there is hydrolysis of these glycosaminoglycans, causes cell lysis, deeper penetration, and that is why an alkali injury is more severe in its sequelae. And as I said, the aim of management is to completely remove the chemical from the eye as soon as possible, control the acute inflammatory reaction and the damage that has been done, and prevent something like this, which if it happens, then it's going to cause a lot of problems as far as visual outcome of the patient is concerned. So we have to do immediate management, and the first and foremost thing is to remove the chemical, remove the agent that is causing the damage. So irrigation should be done thoroughly, at least for 30 minutes, and it should be continued till the pH stabilizes. What is most important is that many times we do irrigation and we check the pH immediately after that, which gives the pH of the saline with which it was being washed. But what we should do is we should thoroughly wash the eye with saline, maybe for 20 minutes, 30 minutes, whatever time. Check the pH after waiting for 5 minutes, so that if there is any chemical there inside the eye, it will get released and it will get the pH accordingly. You should invert the lids, do double immersion and all that, and then remove the chemical completely from the eye, so that you can see if you reach the pH of 7, that is the end point of the removal of the chemical. And as I said, immersion of lid is very important, and double immersion should be done in order to check for any chemical that is there present in the cul-de-sac. That is very important. And there are various methods, various solutions with which one can clean the ocular surface. Of course, BSS Plus, which is the most useful solution for any intraocular procedure or any extraocular procedure, has been found to be the best. But I would say even tap water is very good. What is most important is the urgency, is the rapidity with which one should act. The chemical should be removed completely as soon as possible in order to prevent damage. That is the most important thing. And once the chemical has been removed, you have to assess the severity. You should check the epithelial defect. You should check the limbal ischemia, and then grade the severity of injury. Now, grading is not only for academic purpose, but also to tell the prognosis to the patient and also to plan the management, that what all you need to do. So grading has been done classically by the Roper Hall classification. But then what happened that there was a fallacy in Roper Hall classification, that in grade 4, it was taking all the cases of more than 50% limbal ischemia, which had some cases at 60%, some had 95%. So the prognosis was different. And that is where Dua's classification came into practice. It classified the grade 4 of Roper Hall into 3 parts. And then also the conjunctival involvement and all these things were taken. And that is how studies have shown that in terms of explaining the prognosis, in terms of prognosticating the patient, Dua's classification has been found to be better. And once the chemical has been completely washed off, debridement of the necrotic material should be done. The patient should be put on drugs which will provide symptomatic relief, which will like analgesics, topical antibiotics, which are epithelial friendly, something like chlorphenicol, intensive lubrication, topical cycloplegic, and topical steroid, because we want the inflammation to subside. We also want collagen synthesis, so we would like to give sodium ascorbate as well as tablet vitamin C, and of course sodium citrate for some time, and collagenase inhibitors like doxycycline can also be useful. Autologous serum has been found to be effective, and we did a study at RP Center comparing umbilical cord serum, using umbilical cord serum in these cases, and we found that umbilical cord serum was even better than autologous serum. What I would like to emphasize is this, that many times the chemical, it penetrates and goes underneath the conjunctiva. That will keep causing damage, keep causing necrosis of the sclera and the surrounding adnexa. What is most important, that if you get to see that there is any chemical even in the subconjunctival region, then peritomy should be done. All these chemicals should be removed, and it has to be removed thoroughly. You may have to remove some charred tissue as well. And once you have done that, you can put an amniotic membrane over the ocular surface. Amniotic membrane has been found to be very effective because it not only improves epithelial healing, it also provides symptomatic relief. It also reduces pain. And that is why in these cases of acute chemical burn, amniotic membrane does help, because there's a general thinking that any surgical intervention in an acute stage may not be useful. We performed a study at RP Center. We found that role of amniotic membrane is in preventing, in improving the epitheliation as well as improving, reducing pain. And it has to be done on the whole of the bulbar conjunctiva and the palpebral conjunctiva. Everywhere it has to be done. This is the post-op picture in one of the case, and this is the study which we published back in the Journal of Ophthalmology. And there are some more studies which have come which showed that amniotic membrane transplantation is very useful in acute burns. In order to prevent stromal ulceration, in order to prevent further damage, in many of these cases, tenonplasty is very useful. And as I was telling that, once you see the grading of injury, if you have severity like this, in such a case wherein you have a high degree of limbal ischemia, you should not mind using tenon cases, because tenoplasty improves vascularization, it improves healing and prevents. It is really very useful in these cases. Now, if we have a chronic sequelae like persistent epithelial defect or conjunctivalization of cornea, there is bad pannus formation, etc., we have accordingly. Now, if we have a persistent epithelial defect, amniotic membrane transplantation is very useful. So this is something which we have found that it improves. What you have to do is you have to roughen the edges of the defect, because once there is a keeping up of epithelium at an edge of the epithelial defect, the epithelium does not migrate. So you roughen it up and then put an amniotic overlay, and that is really useful in improving epithelialization in these cases. Sometimes you get to see a case of pseudoteregium. Now here, because of the pseudoteregium, the patient has astigmatism, so this pseudoteregium has to be released, and then of all the fibrotic tissue, and then the surface is covered with an amniotic membrane, and that is how you maintain the ocular surface. Sometimes you get to see a case, very bad case, wherein there is whole of symblepharon and chyloblepharon. The patient was a case of chemical injury, wherein the patient was lost to follow-up, and we were dissecting. We could see that there was presence of a bandage contact lens, which was removed. And once it was removed, further pannus dissection was done, and in the pannus dissection, the amniotic membrane transplantation is being done. People really worked very well in these cases. And then after putting the amniotic membrane, in such cases, symblepharon ring is a must, because in order to prevent the symblepharon formation again, you have to do it. Now, limbal stem cell transplantation is something which is very useful in all these cases, because these chemical injury causes damage to limbal stem cells, and that results in conjunctivalization. So because the whole 360 degree there is conjunctivalization, you cannot take the limbal stem cell from the other eye, the whole 360 degree. And what we have found out in studies that cadaveric stem cell has a very high failure rate, nearly 100% failure rate, unless the patient is very particular about systemic immunosuppression. So what we have now started doing is that ex vivo expansion of stem cell is done. We take a small lenticule from the other side, and then it is expanded in the lab, and then it is transplanted into the eye where there is a bad pannus, and after pannus removal, we place this cultured limbal stem cell onto the ocular surface, and the results have been found to be quite good depending upon the type of case. Now, because we used to culture these limbal stem cells in the lab, it was thought that the ocular surface, if you over the ocular surface, if you provide something as growth factor, something like amniotic membrane, which can provide growth factor to the limbal stem cells, we can directly place small tissues of limbal stem cell from the other eye, small lenticules, small pieces, after dissecting the pannus, and that can also work as a culture of limbal stem cell. So basically, it is not ex vivo expansion; it is expansion being done on the patient's eye. So this is the complete removal of pannus, and a little bit of cartilage being done. The other eye is being used to take the limbal tissue, and once the limbal tissue is taken, it is It is cut into multiple pieces. The amniotic membrane is being placed onto the ocular surface after removal of pannus. And then over the amniotic membrane, these small pieces of limbal stem cells can be put after putting the fibrin glue. And it is placed in all the quadrants so that you have expansion of limbal stem cells from all sides. And this technique of slit is very useful in most of these cases. Yes, you have to do a good case selection if there's a very bad pannus formation and conjunctivalization and symblepharon formation on all sides. It's better to do symblepharon release and then put amniotic membrane and then do slit at a second sitting. But in cases like this, wherein you have a quadrant here and some loss of limbal stem cell in the other quadrant, you can manage it with the slit in the as the first procedure, and it works quite well. And as the last procedure, if we have a very bad scar, full thickness scar, conjunctivalization, badly vascularized scar, then you can do a keratoprosthesis in these cases. So in conclusion, ocular chemical injury is a medical emergency. It's an ocular emergency, and rapidity is the key. We should try to be as fast as possible, remove the chemical as fast as early as possible, and as complete as possible. And then, of course, one can do a medical reparative therapy, cord serum, amniotic membrane transplantation. All these are very useful in acute conditions in order to prevent damage. And once there is formation of sequelae, there is formation of pannus, etc., then we have to do pannus release, and the simple limbal epithelial cell transplantation is a very useful tool in forming the ocular surface in a better way. So thank you very much for your patient listening, and I'll be happy to
Thank you. Yeah, thank you, Dr. Rajesh. That was a really excellent talk. You have covered everything, and your videos were really superb. I think if we can should have the discussion at the end, would that be okay? Or if anybody has any questions to ask now? I think we'll have the discussion at the end, so that if anybody has any doubts. So the next talk is by Dr. Manoj Prahtapan. So he will be Dr. Manoj Prahtapan. He'll be talking about this problem, intraocular pressure rise in following trauma. So we all know that glaucoma is something which can cause immediate loss of vision as well as long-term loss of vision, even in eyes which have been very well managed. So it is something which we cannot afford to forget following trauma. So Dr. Manoj Prahtapan, he is the Associate Professor of Ophthalmology at the Amrita School of Medicine, Amrita Institute of Medical Sciences, Cochin. He did his MS Ophthalm from Amrita Deemed University. Later, he did his long-term fellowship in glaucoma from Arvind Eye Hospital, Madurai. He was awarded the Best Video Award, Dr. Tony Fernandez Best Video Award at the 2020 Registry. Over to Dr. Manoj.
Thank you, sir. Thanks for giving the opportunity to present here. My topic is high intraocular pressure following blunt trauma. I hope my video and audio are clear.
Yeah, it is clear.
Okay.
It's clear. Yeah.
So first, we should understand the etiopathogenesis of raised intraocular pressure following a blunt trauma. Various mechanisms are possible. They may come as independent mechanism or as with multiple mechanisms in the same patient. So over the course of this talk, we will go through each of them. The risk of glaucoma is about 3.39%. We can classify glaucoma as early onset or late onset glaucoma. The early onset pathophysiology could be because of direct trabecular meshwork disruption, edema, traumatic iritis, and choroidal hemorrhage. The trabecular meshwork disruption can be seen on gonioscopy as a trabecular flap with hinges at the scleral spur. You may also see a full thickness tear in the angle with gonio blood. This may not lead to early or prolonged high IOP, but may lead to late onset IOP due to healing, which causes scarring of the drainage apparatus. The ciliary body collapse usually causes low IOP, and always look for angle recession on gonioscopy. Next, going to hyphema. The source of bleed is from the iris or the ciliary body. The mechanism of glaucoma is trabecular clogging with an open angle mechanism. There is a rebleed of about 10% possible. So usually happens after a week of the initial trauma. This is because of the lysis and retraction of the clot. So the risk of rebleed is more in patients who are on aspirin with the elevated intraocular pressure or even hypertonic. The risk of hyphema is more with the larger bleed, and the incidence of IOP varies with the size of the hyphema. There is a 13.5% risk of incidence of high IOP in patients who have hyphema of less than 50% anterior chamber hyphema. And it doubles to about 27% when the hyphema is more than 50%, and it again doubles to around 52% when the hyphema is total. The high IOP may also arise after rebleed. We should always differentiate a total hyphema from an 8-ball hyphema, which is shown here. It's a completely dark-colored anterior chamber filled with a large blood clot associated with the vitreous hemorrhage. In a patient who has sickle cell, there could be high IOP even with a small amount of hyphema. Even moderate intraocular pressure can cause optic nerve damage, and we should avoid use of oral carbonic anhydrase inhibitors because they can produce sickling of the blood in the anterior chamber. Type 2 diabetic patients may have a delayed hyphema clearance because their RBCs are less pliable. Now coming to corneal blood staining. Clinically, the initial part, the stroma appears slightly reddish, but soon it turns brownish discoloration. The risk factors for corneal blood staining is a prolonged total hyphema with an elevated intraocular pressure. The hemoglobin is phagocytosed by the keratocytes and degraded by hemosiderin. The management is self-resolving, but it may take a long period of time. And the clearance happens from the limbal side towards the center, so the visual regain may happen later. Management of hyphema. The measure should be taken to prevent rebleed. So RBCs clear with ease through the conventional pathway, and high intraocular pressure here are usually transient, and we can tide off the period with the use of systemic and topical anti-glaucoma medications like aqueous suppressants. No role for PG analogs. The surgical management may be required if the IOP is threatening to damage the optic nerve head or it is associated with corneal blood staining. What are the indications for hyphema drainage? If there is a total hyphema of more than 4 days, 40 to 50 millimeters Hg pressure of 5 to 6 days, more than 30 millimeters mercury pressure of 1 to 2 days in a pre-existing compromised disc. But in patients who have sickle cells, the threshold for drainage is low, and even because mild or mid-20s pressure for more than a day can produce optic nerve damage. So what is the pressure? In the patients who have liquefied blood, make a side port and gentle do irrigation alone without aspiration. We should not try to dislodge the clot because it can produce rebleed. The clots can be left there so that it can self-absorb. If there's a large blood clot which needs to be decompressed, we can use a visco dissection and expression through a corneoscleral tunnel. Vitrectomy cutter is very good to debulk the blood clot. Day 4 would be an optimal time to do this because by the time the blood clot retracts and there's a less chance of rebleed. If there is a rebleed which happens intraoperatively, it can be controlled by raising the intraocular pressure for about 5 minutes or viscotamponade. Long-term management is not required because these IOPs usually come back to normal range, which may, or if there is mildly elevated, we can manage them with intraocular anti-glaucoma medications. The risk for the risk for high IOP following chronic IOP following hyphema is there is heavy gonio pigmentation, higher baseline IOP, angle recession, and lens subluxation or cataract. Traumatic iritis produces glaucoma by direct trabeculitis, increasing the trabecular resistance, and the management is topical steroids, cycloplegics, and aqueous suppressants. Next, coming to choroidal hemorrhage, the risk of glaucoma is more when there is a choroidal hemorrhage is more when there is a trauma is very severe or the patient is on anticoagulants. The mechanism is a push mechanism The choroidal hemorrhage pushes the iris lens diaphragm forward, causing a uniform shallowing of the anterior chamber, both in the center and the periphery. This causes an acute rise in intraocular pressure. There is a reduced reflex and a retrolental mass or choroidal elevation. Management. Start off with the topical and systemic anti-glaucoma medications and topical and systemic steroids with cycloplegics. The surgery is indicated when there is a large choroidals, when there is a lens corneal touch, and persistent high IOP. Wait for liquefaction of the blood if it is possible for 10 to 14 days. The steps of choroidal drainage is best left to a retinal surgeon. A peritomy is done. Identify the quadrant with the highest elevation. A 4 to 5 millimeter long full thickness incision is done behind the rectus muscle, and the drainage is facilitated with the AC maintainer or viscoelastic in the anterior chamber. Multiple quadrants may have to be done. The paradoxical rise in intraocular pressure may happen in the setting of a rhegmatogenous RD with tears in the ora serrata because of clogging of the trabecular mesh with the photoreceptor outer segments. The treatment here is to do a retinal deattachment surgery. Coming to late onset glaucomas, we have angle recession glaucoma, gaussian glaucoma, hemolytic glaucoma, hemosiderotic glaucoma, and lens-induced glaucomas. Angle recession glaucoma happens in about 4 to 9% of patients who have more than 180 degrees of angle recession. Angle recession itself is not the cause for glaucoma. It just shows that the trauma was severe enough to produce angle damage. And this angle damage initially could have been compromised the remaining normal trabecular mesh, but as the patient ages, the trabecular mesh resistance also increases, which may later on lead to high IOP in these patients. It is more seen in patients who are predisposed to get glaucoma, like patients who have family history of glaucoma. And many often we see these patients with other eye also having a primary open angle glaucoma. Angle recession is seen as a tear between the longitudinal and circular muscles of the ciliary body, and gonioscopically we see a irregularly widened ciliary body band. It presents later in life similar to a POG, which is mostly asymptomatic or without any pain or redness with optic nerve cupping. It may be unilateral or bilateral. Bilateral because the other eye may be having a primary open angle glaucoma. The management is anti-glaucoma medications. Trabeculectomy IOP is not getting controlled with medications. We can even do a glaucoma drainage device or a micropulse diode photocoagulation. Next, coming to ghost cell glaucoma. The mechanism of glaucoma here is the degraded RBCs from the vitreous gains access into the anterior chamber and then clogs the trabecular mesh. The biconcave shape of the RBC is changed to a spherical, less pliable shape in the vitreous, and once they gain access in the anterior chamber, they can cause this glaucoma. It develops about 7 to 10 days after the vitreous hemorrhage occurs. Clinical features, we see khaki colored cells in the anterior chamber and on the endothelium. The candy stripe sign is when there is a layering of khaki cells and fresh blood. The management is the transient IOP lasts for about few months. It may range from mild to moderate, mild to severe intraocular pressure, and most of them self-resolves once the cells clear the anterior chamber. So if medically uncontrolled IOP, we can do an anterior chamber wash and a complete vitrectomy. Next is hemolytic glaucoma. The macrophages engulf the RBC products and the trabecular mesh gets clogged. This can be confirmed by doing an aqueous cytologic examination. Hemosiderotic glaucoma, the endothelial cells of the trabecular mesh engulfs the hemoglobin, and in the hemoglobin causes siderosis and tissue changes. Next comes to lens-induced glaucoma. The lens subluxation or dislocation may be the reason for glaucoma. The mechanism of this kind of glaucoma is usually secondary angle closure glaucoma. Here both pupillary block mechanism and without pupillary block mechanism are possible. Here in this case, we can see the lens is completely luxated into the anterior chamber, causing a pupillary block. Whereas in these kind of cases, where the lens zonules are lost in 180 degrees, it may be pulled to one side, and that particular quadrant may have an iridocorneal touch. And here there is no role for a laser PA. We need to remove the inciting cause, which is the lens. Otherwise, over time, there will be a permanent peripheral anterior synechial formation and a persistent IOP. Thank you.
Anup, mic is not. Anup. Your mic
Thank you, Dr. Manoj. Yeah. So you have really comprehensively covered all the aspects of glaucoma following trauma very systematically. So I think we'll now come to the next topic, and after that we'll have discussion. So the next talk is on iris injuries. We all know that all anterior segment injuries will eventually have iris problem, iris injuries also. They are associated. But many times we just focus on the focus only on the corneal part of it. The iris injury or tissue loss is just kept like that. But most of the time, this iris loss in iris tissue many times leads to a lot of reduction in quality of vision of the patient. We all know that many these people keep coming for years together, complaining of glare and photophobia and loss of contrast, etc. So we have now a very charismatic surgeon who will be talking about the management of iris injuries. So we have Dr. Prasanth Bhavankule today here. He's basically a vitreoretinal surgeon. He did his, he's the founder director of Sarakshi Netralaya in Nagpur. He did his VR fellowship from Shankar Netralaya and then later continued as a consultant there. He is also honorary associate professor at his alma mater, the Indira Gandhi Medical College, Nagpur. He has got various achievements to his career. He has won the IRSI gold medal in Chennai in 2021. The Best Video Award at the World Congress of Trauma in 2019. He has won various gold medals and free paper awards of different state ophthalmic societies. I am not enumerating all of them here. And he is one of the pioneers of 3D digitally assisted surgery. He has done a lot of work on that. He is propagating this new model method of surgery. He is a treasurer of the VRSI. He is a treasurer of the OTSI. He is the past president of the Maharashtra Ophthalmic Society, and he has got a host of publications in national and international journals to his credit. So with these few words of introduction, I invite Dr. Prasanth to start his topic on iris injuries.
Thank you. Thank you, Dr. Ru. I would share my screen first. Is my screen visible now?
Yes, sir. It's visible.
Okay, 1 minute. So good afternoon, friends, and thank you, Kerala Ophthalmological Society and Thrissur Ophthalmic Society for this wonderful opportunity besides my own society, that is Ocular Trauma Society of India. So friends, iris or the uveal tissue is the most neglected tissue when it comes to trauma. We try to salvage the sclera, we try to suture the sclera, we try to suture the cornea, we look at manage the lens, we take care of the vitreous hemorrhage, we manage retinal detachment. But when you have iris tissue loss, most of the times, most of the surgeons just excise it, leaving that eye uniridic. So these are the various causes which you have, and trauma is one of the most important causes of iris abnormalities. And why is it important is that basically it causes glare, visual disturbances, photophobia, and importantly, a loss of cosmesis to that particular patient. Importantly, you put a beautiful pseudophakic, but he has a glare problem in spite of putting a monofocal lens. And that is the reason why we need to salvage this eye and try to repair and give him a near normal pupil and a iris tissue. These are the varied scenarios when you have iris tissue. These are the congenital scenarios like coloboma, you have mydriasis, traumatic, iridodialysis, and aniridia, which can also be traumatic in nature. So let us see through this video bouquet how we try to treat it and how a beautiful pupil can make a patient's life in a post-operative period better. Now, this is a case of a coloboma. We have done a thing. This is a case of a congenital coloboma, but yes, many a times during trauma you can have, well, we are doing a fourth row knot pupilloplasty over here and just suturing the fourth row knot. This is a 23 gauge needle. This is a proline suture, 8 of proline suture. Now we are creating a fourth row knot over here. And once a fourth row knot is just, you have to put it, pull the two ends from the various ports which we have created, and you can see the near normal restoration of the contour. So this is the pre-op photograph of the patient who had such a distorted pupil, and it was off the optical axis, and so we could rehabilitate him, and patient had a lot of better symptomatology. Now this is a mydriatic pupil. We have these are the various options which are there, which can be given. We will share a few of our videos. Now here in this particular case, the whole iris tissue is incarcerated into the scleral tear, which was there here, which was repaired elsewhere. We have done a SFIOL for a traumatic cataract. And now simple procedures like that, I'm just pulling it with the help of a vitreous or irrigation aspiration port, pulling that, releasing that iris tissue, which is incarcerated into the inner lip of the wound. And you can see the normal restoration. This was the pupil previously, and this is near normal, and pupil is reacting, and the patient has his problem solved a lot. Now this is a pupillary cerclage. This is a video which is borrowed. I don't do it. EKMF video where a beautiful demonstration how such a large traumatic pupil could be brought into normal. It's a slightly difficult technique. I have not tried it, but for the sake of viewers, I would just let play a borrowed video from YouTube. I'm just sharing with you. You can see that Prolene sutures which is being passed across the pupillary edge, and at the end you can have it is passed through all across 360 degrees, unlike the fourth row knot. And here you have more circular pupil, and this is at the conclusion of the surgery. This is pinhole pupilloplasty. Now this is a video from our own coverage. This is a traumatic and mydriasis with a subluxation lens. We have completed the scleral fixation of the lens, and here after releasing the suture, now I'm doing a fourth row knot pupilloplasty here. You have to pull the iris, which is slightly retroflexed, and once the suture is passed through, the loop is brought out. 4 throws are created. Now the sutures are passed through this knot 4 times, 4 knots. So it becomes 1, 2, 3, 3 and 4. I think the video we have deleted that part, I believe, during the editing part, and then just trim it, and you have a near normal pupil. As you can see in this particular case, this was the pre-op photograph, and this is the post-op photograph of a patient. Another case of traumatic phakia and a tissue loss. Here again, the associated with the mydriasis is also the tissue loss, and here the challenge is in trying to create a pupil. After stretching the pupil, releasing it from whatever adhesions it has to the cornea, iridocorneal adhesions. Now I'm doing a fourth row knot. Here I would be, so at this particular place, the loop is being brought out. And after that, once the loop is got out, you have to pass the 4 throws through it. And once you have a 4 throws, you just have to pull the 2 ends of the 8-0 Prolene suture. So here we have reduced. You can see there was such a loss of tissue over here. Now I have snapped that, and now I'm again taking it at the superior edge. Same thing, again a 4th row knot pupilloplasty is being done. And you can see at the conclusion of the surgery, near normal pupil, and this is the pre-op photograph and the post-op photograph. This patient is extremely happy. He has a good 612 vision because this posterior segment was quite spared. Now this is another case where you can see a large pupil. This is totally retroflexed iris. The iris was totally retroflexed because of the trauma, old trauma. We have done a cataract surgery, SFIOL is done. Now we are trying to pull out that retroflexed iris, trying to bring it, identify the iris plane. And again, after having released the retroflexion, 4th row knot is being done with the same 4th row knot pupilloplasty being done. And you can see, so passing through this, here the tissue is quite brittle, I should say, basically because it was an old thing. And that's why when we are trying to pull that retroflexed iris, there was a small amount of iridodialysis, which you will note during the superior part of it. And here there is also no tissue as well. So this is the challenge in such cases of trauma. Here I'm pulling the knot out. And as you can see over here, near normal restoration of the contour, and the optical axis and the visual axis now matches here. Though we created a dialysis because the tissue was really friable, iris tissue was really friable. This is pre-op photograph and this is the post-op photograph. Now coming to, this is a case who had a traumatic cataract surgery done elsewhere. So we have done, he was aphakic, there was a sector iridectomy. Again, simple 4-throw knot pupilloplasty. I will just, it's the repetition of the procedure. So I would just show you at the conclusion. This is how the pupil looks now. So this is the pre-op photograph and this is the post-op photograph intraoperatively. Now, other challenges in a trauma is about the iridodialysis. These are the various treatment strategies. If it is less than 3 clock hours, well, you can leave it, especially so if it is in the inferior quadrant. But yes, if it is more than 3 to 6 clock hours, you can use these various strategies, which is given there. Now, this is a traumatic cataract with a corneal scar with a minimal amount of tissue, iris tissue. I'm trying to construct whatever best amount tissue available using this various techniques. I'm trying to insert that small leftover tissue pieces over there. And after bringing out there under the scleral flap, you should do, because if you leave the knot there, it can really erode through and can give you a lot of, patients can have a symptomatic problem there. So you can see at the conclusion of it, after having tried through this various techniques, now I'm again suturing there, and you can see the conclusion. This was the picture, and this is near you. I couldn't have a tissue over here, and that is why at least this part was taken care. Now, this is another extreme case where you have a iridodialysis here, and the whole iris is piling up in the central part of it. He also had traumatic cataract. So after doing a cataract removal and placing the lens inside the bag, I would just move to the iris tissue that is of concern. First, what I did was, with the help of iris hook, while I was doing phaco, I pulled off that tissue iris so that it does not come in your phaco handpiece, phaco while doing a phaco. I think, yeah. And then I'm creating a scleral flap there where I will be putting the suture, or that iridodialysis will be tucked in there into that scleral flap with that atoproline suture, non-absorbable suture. Again, it is going back and I'm getting out the suture. That loop is now brought out. As you can see, the dialysis is almost tucked into the sclera there. After that, I'm trying to create a smaller pupil. Now this is 4-throw knot pupilloplasty. So you can see in this particular case, this was the picture pre-operatively, and this is the post-op picture where you could have a circular pupil, cosmetics taken care, glare, and optical axis as well as the visual axis now matching together. This is another extreme case where you can see the whole iris tissue curled up here. There is no iris tissue over here. There is iridodialysis here. And this is the picture surgery. So after doing the cataract surgery, I will just rush through the cataract. After having finished the cataract surgery and putting the lens in the back, now this is the time to repair. Meanwhile, while you're doing phaco, you have to be careful. You do not, your probes, especially the aspiration ports, can pull in the iris tissue and can lead to further disinsertion. So you can use take the help of iris hooks and all to prevent it from coming into your phacoactive aspiration ports. So this iris tissue is uncurled and first tucked over there at 6 o'clock position. First, you have to really literally check it where it should be ideally placed. So now I have tucked over there under the sclera, atoproline. Now I am trying to test whether I can get these two ends to create a circular pupil. I wanted to anchor this particular dialysis further. Yeah, so I'm trying to, again with the help of atoproline, it is being anchored. And once that is anchored, then the pupilloplasty is being done. So now you can see the iris has covered almost this part. Now only this part of iris tissue is missing. So I am trying to join these two areas. There I will be using a 4-throw knot pupilloplasty. And this technique is propagated by Dr. Amar Agarwal. So after creating a pseudo pupil, now I have tucked over here. Now this particular which was disinserted, now I'm trying to tuck it over to the scleral subscleral flap. And this is the pupil at the almost conclusion. You can see near normal, the tissue loss, which was such a significant. There was a tissue loss as well as near total more than 270-degree disinsertion with tissue loss. So this is the pre-op and this is the pre-op and this is the post-op picture where you have a circular pupil. Well, rarely you can have an aniridia which are managed by various techniques. In a case of a trauma, this is a traumatic aphakia. We wanted to have with a total aniridia, and you can see we have decided to put an aniridia lens. Aniridia lens, you get only custom. You have to customize it. Second thing is they are available only as an option as a rigid lens with a haptic with optic, which is a more than 12 millimeter. Second thing is it has to be tucked in with the help of atoproline suture, but I do not like, so I decided to do a scleral fixation of a aniridia lens. So after doing the necessary steps, I'm creating a flap over there like a classic scleral fixation. I put a infusion cannula so that there is no hypotony while I'm doing all these steps. Now I'm creating a tunnel where I'm going to put the lens. Now the lens is being put, and after lens is put, I put it in the antechamber now. And then the haptics of a rigid IOL were brought out through the scleral flap, subscleral flap, and then it is, you can see here the haptic, first haptic and the second haptic over here. These are single piece rigid lenses. You can definitely do it. It's a bit tough. Sometimes they are fragile and they break it. So you should always have a spare in such cases, because scleral fixation, unlike the suture fixated, scleral fixated, such lenses have more stability. That's what we have realized over a period of time. And so this is at the conclusion. This is previous and this is post-op. This is another case of a patient with an aniridia. I would just run through this. This is post-op day 1, and this is that cataract with aniridia. I will just run through this particular case, and I have put the scleral fixated, means a rigid aniridia IOL into the antechamber. Now I have brought out the haptics, as you can see over here. This haptic, and then it is buried into the tunnel like a classic scleral fixation. And this is the pre-op and the post-op picture. So friends, addressing an iris abnormality, creating a good pupil which should match the visual axis as well as the optical axis will reduce the patient's glare, and he will have a better quality of vision. Besides, his co-partner will appreciate the beauty of having a beautiful eye. Thank you once more. So do respect iris and try to reconstruct it.
Prasanth. So I think we have come to the end of this session, and what Dr. Prasanth has shown here is what Dr. Natarajan also said, and Dr. Ashok Grover, that never give up. Because the last few surgeries, I think there was, it was like really took a lot of time doing that, because
Yes,
a lot of patience at least, definitely.
Basically, time is immaterial when you're looking for a long-term gains of a patient. Yes, this definitely takes more time than the routine cases.
Yeah.
They really demand sometimes in between the case, you really feel, yeah, you should chew up that iris and move off and finish off your cataract part and get out. But no, the happiness which a patient gets after having a good pupil and the pupillary axis matching optical and visual axis is definitely worth the efforts and the time.
So do not give up is a very important thing, because we have a study which is published in 28% no PLIs people gain vision. So never give up. No PLIs is a very different area to work with. And we have experienced that very easily we can gain at least some vision with these patients.
And sir, is there any role for aniridia contact lenses?
Yes, aniridia contact lenses, what happens, we need to understand these patients have a difficult corneas most of the time, Dr. Manoj. So placing a contact lens, which is, and usually if you see such traumas, they come from a lower segment, lower strata of the society. For them, carrying a contact lens and the irregular corneas, maintaining that aniridial contact lenses is slightly difficult. So these patients want one-time solution, and you can definitely give them a one-time solution. Yes, not all, but most of them.
And what about the other iris rings are there? No?
Artificial yes, iris segments or iris rings are also an options when you have it, say about 180-degree tissue loss, and you do not have an iris tissue left over where you can implant. But those things we have to procure, and they really turn out very costly. Unfortunately, as I said, most of these traumas which we come across in our area is in a labor class, and the class who can't afford those iris segments and all cost you thousands of rupees. And
excellent work, Prasanth. Really wonderful.
Thank you, sir.
Enjoyed all the videos.
Eye opener, Prasanth.
Thank you, sir. Thank you.
Also, it decreases the peripheral aberrations of vision and also decreases glare, better driving.
Exactly.
And the quality of vision definitely improves.
Yes.
No, as Dr. Amar Agarwal has shown in some of his videos, even a cylinder of 8-degree or 8 diopter or 9 diopter, if you have a pinhole pupilloplasty, you don't need a cylinder. So it's a pinhole effect. So if you can really bring down that small size of a pupil, even refractive correction is taken care in a badly scarred corneas.
So you recommend an 80-proline?
80-proline, yes, ma'am.
Can we use 10-proline?
Yeah, very true. We can use, but they are really fragile. 80-proline has been documented and people have been using it, and they are really small sutures. They are really small sutures. When you try to manipulate, at least when you are learning, do try with 80-proline. 10-proline can be a later on part. I don't know about the long-term disintegration of 10-proline, but 80-proline has been proved to be quite stable.
Can I just add one point here?
Yeah, Rajesh.
Yeah. Actually, I use 9-proline for all these pupilloplasties and even the suture fixation of any lens, because studies have shown that 9-proline the disintegration is significantly lesser than 10-proline. So 9-proline I have been using. I have never used 80, but 9-o even in studies there's no report of any disintegration. So that is why that is something which is used most often. And even for pupillary reconstruction, I always use 9-proline suture.
Okay.
Prasanth, you should, for a scleral fixated lens, you should try our lens. That will be very convenient and it will save a lot of your time.
Sir, we want even an aniridia lens to be designed by you. That will make our life more easier. Unfortunately, there are a lot of patients who are total aniridia post-trauma, which will definitely because in the absence of iris segments in our country, it should be a good viable option.
Dr. Prasanth, you are using a irrigation cannula for most of these cases. Since you are a VR surgeon, probably that is more, you are very comfortable with that. But for anterior segment surgeons, this problem, the AC keeps shallowing, even if you use viscoelastic.
I think there is merit in this. Glaucoma surgeon may be highlighting something, because by using only irrigation solution and not using visco, the secondary glaucoma incidence can be minimized.
Anup sir, if I answer your question, I get your question right. The thing is, you need to understand this, all manipulations are being done in the anterior chamber in a scarred corneas. So if you have a jet of fluid which is happening and the suture going through it where you have to hold it, it becomes more difficult. And so placing an infusion cannula is not at all difficult. I think most of the anterior segment surgeons who can do wonderful phaco surgery, placing an infusion cannula is more of a mental block than anything else.
But we may not have those plugs and everything. I think most of them may not have, because this is something very rare procedures.
No, these are now market. They are readily available. They're
costing freely available.
1,000 rupees, sir. Indian companies. You just have to have a eye globe should not collapse. That is the basic. And these are prolonged surgeries, bigger incisions, and you are manipulating in anterior segment. So you want there no current of flow, water flow.
Yes, Dr. Rajesh.
Yeah.
Dr. Rajesh, you said you use, you prefer slit over iris, I mean the cell culture, limbal cell culture?
Yeah, true.
Yeah. Why? Because it has
Actually,
got a better result?
this technique of slit has really changed. I mean, thanks to Dr. Sangwan who initiated this technique, because the growth of cells, they are more or less the same as if you do in vivo culture. So that is why slit these days has become the preferred technique by most of the people who are doing ocular surface.
Okay.
Yeah.
How many weeks does it take usually for the whole thing to?
Sorry?
How many days it will take the slit procedure to replace?
How many?
Days. How much time does it take?
For the surface to get reconstructed?
Yeah.
See, it is variable. It depends on the amount of damage that is there, but it is, gradually with time, maybe about 3 to 4 weeks time, you will definitely see a significant ocular surface, which is much better than what it was before. Sometimes what happens that you have to, what is most important, what I have felt over the years is that the selection of case is most important. If you have a very bad pannus all around, then in that case, I would prefer to just remove the pannus and do an amniotic membrane transplantation only and not use the limbal cells of the other eye and keep the limbal cells preserved for a subsequent procedure, which I will do as a second stage procedure to improve the ocular surface. So, and if it's a small 1 quadrant involvement or between 1 to 2 quadrant, partly involving the limbal corneal area, then in that case, maybe at first stage, I will do a slit. So again, you have to select the case properly, and that is how you have to see to it that you preserve the limbal stem cells of the other eye, and so that you can use it at a time when it is most suitable.
Do you have to changing the amniotic membrane? Because usually in our hands, at least, it doesn't stay very long. 2 to 3 days off and then it goes off.
No. What happens is that when you place the amniotic membrane, then you put the limbal lenticule, and then over that you put a bandage contact lens. Okay.
And then last, this amniotic membrane?
Yeah. So it stays for longer period. It stays over there for a longer period, and you keep the bandage contact lens there. You can see the growth of cells, and that is something which, I mean, if you put an amniotic membrane just like that, it may fall off early. But when you are placing an amniotic membrane over the corneal surface, sticking it with glue, then put limbal stem cells, and then put a bandage contact lens over it, then it stays for longer.
Thank you, Dr. Rajesh. And one question for Manoj. Manoj, you're there?
Yes, sir. Yes, sir.
Yeah. Manoj, you said in cases of angle recession, even there's increased chances of glaucoma in the other eye also. I have also read some studies up to 50% chance of glaucoma developing later on in the other eye also.
Yes, sir. That is because who develops glaucoma? The people who are predisposed to get glaucoma. So a trauma in a predisposed eye produces angle recession glaucoma. If a patient is not any predisposing factors, then the risk of getting glaucoma is less. So when you take all the patients who have developed angle recession glaucoma, we may see that the other eyes are also having glaucoma over time. That is a POAG developing, because they are normally predisposed to get glaucoma. They would have already actually got POAG otherwise, even if they had not had a
So it is the recession which is just a risk factor in a way.
Risk factor for, there will be this eye will be affected more than the other eye.
Okay. And again, the extent of angle recession is not related to the incidence of glaucoma, is it? Even in 1 clock hours also you can get.
You can get, sir, but risk increases when there is a more than 180 degrees of angle
recession. Okay.
Even less than that also, we should counsel the patient for a regular follow-up. Even without angle recession also, patients who have had a hyphema, I would tell them to have a follow-up throughout their life.
So those patients who have like cataract and traumatic acute cataract as well as glaucoma, would you opt for a triple procedure or you will have a
No, so
two-step
most of
procedure?
the acute glaucomas are transient.
Okay.
Hits you early means that glaucoma goes away also without leaving much problem. So the acute glaucomas are mostly we have to tide off the wave by using systemic and topical medications. And if there is an inciting factor which can be removed, you remove that. But the glaucomas that come later on, they are the ones that are going to stick along with us. And those patients, depending upon the pressure, we have to do the filtering surgery.
Another thing, can I ask?
If the speakers are willing.
Okay, sir. I just want to, just want attention of Dr. Grover, sir. Sir, these young adults, yearning members of their family are losing their one eye due to accidents, either traumatic optic neuropathy or rupture globe. But what happens is when they lost job also, especially drivers and all. But when they come for disability certificate, we could only give 30%, which does not give any benefits for them. Yes. So what it should be something more. What can we do?
Yeah, especially this issue of one eye blindness.
Yes.
Is very important for some, for those where the occupation is such that they need a binocular vision. And I think we need to discuss this in the Government of India forums. And
yes.
I would request Rajesh to take it up. RP Center had been instrumental in making some of these recommendations. So there should be something additional for those whose occupational requirement is such that one loss of one eye vision is a total catastrophe for their occupation. So I think this needs to be taken up at an official level.
It is
Many
definitely
insurance companies also, the disabilities they describe as something very severe. These small disabilities actually incapacitate people are not considered at all. So your point is actually really a very good point, Dr. Sinha. Something I think if something can be done.
It's when we sit for disability camps, many people are coming like that, and even our own patients, they lost their job because they became one-eyed, but they are not getting any benefits.
I think we can take it up on behalf of Ocular Trauma Society of India as well. Dr. Mehul, we can keep it as an agenda item for the next executive meeting.
Yeah.
And raise it as an issue.
Thank you very much. One more small doubt actually, when we take up these patients for surgery, regarding the consent, like a lot of, as we are like now more and more private practice people are there. So like any ready-made consent forms are available for this trauma?
No.
There are some which were a part of the AIS consent forms, and DOS has also adopted them. They are available, but the trauma ones need to be much more customized according to the individual status of involvement, which talks about their likely prognosis based on the classification of ocular trauma and the score, trauma score. So I think we need to have much more customized ones for an individual based on the involvement. I think again, we should possibly look at trying to come up with the more specific forms as.
I think, sir, video consent will be very valuable here.
Okay.
Video consent will be very valuable.
In fact, this concern I had raised way back about a year back at APOTS forum also. But that consent issue which Madam has raised is very true. We need to have 3 or 4 customized consent for, say, scleral tear, corneal tears, posterior segment involving. I think we as a society can try and create at least a rough draft of it. I think
with ocular trauma score taken into consideration.
Yeah.
With gaps saying that the ocular trauma score is such, the zone involvement is such, which means such prognosis, I think we can customize these forms.
We can
Right.
your format depending on the type and nature of injuries.
Again, Dr. Mehul again added.
Yes, sir. We can take this.
Let's get a committee to do this.
Okay, we are already running short of time.
And request all of you to become members of Ocular Trauma Society of India so that you can push all these and other matters.
Anybody can, if I can share the form and then you can do this.
We can all collectively do this.
Yes.
Because we need more young hands, more working hands in order to take up all these and many, many more issues.
Sure.
Sir, we had, so to conclude, we had excellent talks from very experienced surgeon, and I hope all of you found this CME very useful. Thank you all. Thank you.
Thank you. Thank you.
Thank you.